પ્રિયતાને પ્રેઝન્ટેશન કેવું આપ્યું છે?
આમાં ઈમેલ પર ये कॉपी करना है आपको इसी कॉपी करना
પ્રિયતાને પ્રેઝન્ટેશન કેવું આપ્યું છે?
આમાં ઈમેલ પર ઈમેલ
તો પાછળ થોડું લાઈક થઈ આવે છે.
કેટલો ક્યુટ લાગે છે.
પેલો મારો ફોટો જો વોક એન્ડ ટોક.
જોયું વીર જોડે ને કેટલા સરસ લાગે. You looking almost as much as બહુ સરસ લાગે છે.
પેલો મારો ફોટો જો
રેકોર્ડ થાય છે.
રેકોર્ડ ખાલી પ્લે થાય છે.
કેટલા સરસ લાગે.
આ ઈ લોક તારે કેટલી મોર તારે આ બંધ કરી દેવું પડશે બીકોઝ
શું
હવે
આ કંઈ don't થાય છે.
હા તો ફીડબેક
અદિતિ જરા જોજે ને કે પેલી લિંક થી જોઈન થવાય છે કે ઓકે તું બી મારા જેવી જરા ઓવર એન્થુસિયાસ્ટિક છે. So you don't trust me. ના ના ચેક કર્યા વગર મોકલવાનું જ નહીં. લાસ્ટ ટાઈમ એવું થયું હતું ખબર છે ને લિંક ખુલતી નહોતી ને બધું. અને બેઉ રીતે લોગિન થવાની ટ્રાય કરવી પેલા એનાથી બી પાસવર્ડ થી પ્લીઝ. હા કઈ વાંધો નથી પ્લીઝ ગો બટ તું છેલ્લે આવી જજે બીકોઝ યુ આર ડુઈંગ ધ both of things. Bye. મેં તમને હાઈ બી કીધું.
This is your presentation. Okay. તો એ લિંક પર જા તો પેલા રૂમમાં જઈને
કઈ
મેં તને YouTube ની લિંક મોકલી ને
હા એને કરી લીધું ટ્રાય.
હા પણ તું પણ ટ્રાય કરે ને because now I have stopped it એટલે I have stopped it here. હા હું આ રેકોર્ડ ઓન ધીસ કમ્પ્યુટર કરું છું. It'll be a huge recording, but it's better to record it on the computer. If you record to the cloud edge karo actually. Lag હશે એમાં કોઈ પ્રોબ્લેમ નથી તો people are who are
બોલ્યો એ અહીંયા સંભાળો મને.
હા but people are cloud પર
Good morning. થાય છે ma'am connect.
Okay, thanks.
Okay, bye. See you.
Bye.
એક જીબી કે ઉભી કે જશે ને તો
Best wishes birthday से wish कर दे. મેં નાનું કાકાને તો કર્યું હતું પછી કરી લેશે તારી ચાકુ
1 GB cloud recording.
Hi
Rasesh,
happy birthday to you.
Happy birthday to you.
તું આજે વહેલો ઉઠી ગયો
Thank you. Nah, just
એટલે જ હું તો ફોન નથી કરતી પણ I saw your message so I thought કે હવે કરી લઉં
એટલે 15 મિનિટ થઈ એટલે I just opened the phone and started looking at it. How are you guys doing? Sasu Sasa, I can't believe now.
Can you imagine?
Is that your way of congratulating us? Sasu Sasa to remind her.
Congratulations. I said I told even Sakhi. Weekend में बात करीस because I want to talk and know about him and all that. So
yes.
She's saying
we are very happy.
Yeah, it was a very nice surprise because you always wonder now where came the music? You are a little hesitant to ask here what's happening.
I know
because they reach that age where they have to find their soulmates.
Yes, but they are also taking their own sweet time otherwise, so you can't ask.
Yeah.
આ તો અમને ખબર હતી 2 વર્ષથી પણ we could also not keep asking her કે હવે ક્યારે આ તો he proposed, she accepted, so we were happy. Short story. Chal, you have a great day. I'm sure that well, I'll talk to you later.
Yeah. But I want to talk to you guys. So
Yeah.
We'll
do that.
Bye.
Thanks, Amir. Bye.
સેમ જોયું હવે ફ્લાઇટ ચાલુ થઈ છે ફર્સ્ટ થી બોમ્બે અરે સવારના 7 વાગે રાતના 8 વાગે પાછા હા પ્લીઝ કરાવ દે બધું મળશે નહીં મને અને 5th છે હા એને કીધું 3-4 પેશન્ટ્સ બુક છે સેમ જો કેટલી બ્રાઇટ એન્ડ નાઇસ લાગે સમીર આ બધું યુટ્યુબ પર આવે કીધું જલ્દી આવે हाँ એક શું કરે છે? હા સમીર સમીર તને નાસ્તો જોઈએ છે? ઓકે તમે એક મિનિટ પથારી કરી છે? અહીંયા આ બાજુ નહીં. એ બાજુ મૂકો. અહીંયા નહીં લૂછતા. એ પછી કરી લેજો. અહીંયા ના મૂકો. અહીંયા દેખાય છે પાછળ. આ બાજુ મૂકો ને તો ત્યાં અંદર મૂકી દો. એવો તો હમણાં ભાઈના કબાટમાં મૂકી દો ને હું પછી કરી લઈશ. પેલી ખુરશી પર મૂકી દો બાથરૂમમાં, હું લઈ લઈશ પછી. હા. Good morning. Hemant bhai, good morning. You can unmute and show your video also. Hi Aditi.
Hello, ma'am. Good morning.
Good morning. કેટલી ક્યુટ લાગે છે.
કેમ છો?
એકદમ મજામાં.
પ્રિયા
આપણે ઘણા છીએ.
પ્રિયા દીદી નો મેસેજ આવ્યો કે she will not be able to. She's not well. એવું just આવ્યો second હતો.
So sad. બહુ માંદી લાગી મને yesterday when I talked to her.
એક મિનિટ ખુરશી લઈને આવો.
Hi Chitra. Hi. Good morning.
Good morning.
Welcome, welcome. So good to see you.
Yeah, but what about the rest?
I don't know. I was thinking everybody would join by this time.
I think on a Sunday.
Starts at 10, but I think we are the enthusiastic and the on-time people.
10 o'clock is too early for a Sunday, I think.
But you know, if you make it late, then the lunchtime becomes late.
Yeah. No, this is very sensible.
Yeah, and we generally start on time and finish on time, so we don't
That's
try
your-
to leave. I know you have so many. I don't know how you manage, Chitra. You're just too good.
Looking nice.
Thank you. Same to you.
Oh,
Chitra,
no.
there is some light coming still from that curtain of yours. It's giving you a hello. Perfect.
Right.
Now you are a self-illuminating object.
No. I have one superb migraine. I've become photophobic also. I don't know
Really?
what has happened. I'm feeling so bad. I was looking forward to your meeting.
But you must be having so many meetings, no? Back to back.
Yeah, we are
But
having
lovely meetings getting organized.
nice, no?
Yeah. In fact, you know, the lockdown is helping in a way to
Helping a
create
lot
better
that-
meetings.
Yeah. Helping hell of a lot.
Because
And-
if you have so many meetings, otherwise people would not attend, right?
And in a hall at any time only 50, 70 or 80 people would
But here so many.
Yeah, so many people attend. So there's so many small finer points all of us learn in each of these
And
meetings.
so many things get
Yeah.
discussed. you
Yeah.
know. I really like to attend.
Yeah, very true. Very true. Yesterday's meeting, I was there for some time. Your refractive meeting, it was nice. But Ramurthy said the younger guys also presented very well.
They would,
which
you know, everybody does so much. But I know he was a little upset that people left early.
Yeah.
And I can imagine, I also know that. But Saturday evening and Sharad Purnima, I think both
I know.
play their role here. Most people will join by 10.
Yeah. I'll just check on Ramurthy and come back.
Yes. Hi Rajeshi. Good morning, Sunil bhai.
नूतन गुड मॉर्निंग
તો સુનિલ ભાઈને બી બોલાવો.
બોલાઈ લો 3 ઓફ તેલ ઘરમાં છે થોડું આવડવું જોઈએ નહીં એમને બી
I know. પણ તમે બંને જણા you are not using your name.
નહીં
રાજેશ્રી આહાના લખી દે છે.
માય લેપટોપ ઇઝ વિથ શાલિન બધું આમ ગોળ ગોળ ફરી
મોઢા તો બતાવો હમણાં આપણે આટલા જ જણ છે તો.
ખુશ્બુ ઇઝ જોઈનિંગ જસ્ટ ના હું ચા લઈને આવું જસ્ટ અ સેકન્ડ
ચાલી આવજો.
Looking very pretty.
ચાલી આવો.
Rupalan, looking pretty. I like this color.
Thank you.
Yeah, it's nice.
Okay.
Rupal has not been partial to the woman folk. See, she's given me the first talk when there's going to be very little audience.
No. I won't start till there is audience. I'll be talking first for the 5 minutes. By that time, everybody will join. And make sure everybody listens to you. Good morning, Dr. Ram.
Hi, morning, Rupal.
Thank you so much, both of you, for sparing the time. Really, I know how busy you are.
It's a pleasure.
It's an honor for me.
So what? This is basically for Baroda ophthalmologists.
It is only Baroda ophthalmic, but I'm also streaming it live on YouTube for other people to see.
Okay. Uh-huh.
But Baroda ophthalmic usually doesn't allow other. So to join, there are only Baroda ophthalmic people who would join.
Uh-huh.
We should have at least 40, 50 people.
The light okay?
Perfect.
Oh, I'm not able to see it.
You both are in different rooms, right?
Yeah.
Otherwise, the echo comes.
Yeah, echo comes.
Even otherwise, echo comes.
What otherwise?
I always get an echo to anything I say.
That's a good thing, no? He's agreeing to everything that you say. Hi, Neeta.
Hi, good morning, everybody.
Good morning. I really wanted to start on time. I wish people join soon.
True.
I'll start at 10:05, not later.
Yeah.
Not later.
It's okay.
Yeah.
You know, Sunday morning, give that to people, but I don't want to delay it.
Good morning, Dr. Chitra.
Left for
Well, when as usual, you are looking pretty.
Aditi, if you can call up Paraj and at least AC should join.
Yes, ma'am, I'll call.
મેં 15 જણને તો રિમાઇન્ડર નાખ્યા છે.
Sunday morning syndrome.
I know, yeah.
Madam.
Did you all join with the link or with the password?
I joined with password.
Okay. Did anybody join with the link?
No, I joined also with password.
Try and join with the link, no? Because I want to see if people can join with the link.
I joined with the link.
Okay.
Yeah, Neeta, I just know
Yeah.
I forwarded the link, so that was the easiest.
Okay. Yeah.
Right.
Good morning.
Ma'am, Dr. Paraj is joined with the YouTube link.
Okay, good.
So there are people on the YouTube link also.
Okay.
Because we've posted, and people will be able to watch it on the YouTube link on their smart TV. So people will probably opt for that option also.
That's true. Then we would start.
How many of y'all? Y'all are 100?
200 is the members.
Then I was wondering, YouTube, पर most some of them would go, you know.
Yeah. Has Parag joined? Hello.
Good morning, Dr.
Good
Partha.
morning.
Hi, good morning. Good morning.
Good to see you.
Thank you. Refractive sessions every day, every night.
Our specs are going to fall off just attending all the sessions.
Hi, Chitra.
That was a nice meeting, Partha. I was there for a bit.
Yeah, it was so good.
Yeah, Rohit and Abhijit's talks fabulous. Means what is coming to refractive surgery? I think we'll all have to go to school again.
Long time no see.
Yeah. Hi, sir. Good morning.
Morning, Partha.
Partha, can you look at your phone?
Rupal, you are muted, Rupal Ben.
Yeah.
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 So I was teaching lip reading.
Whether we have cataract or not depends on that. Yeah.
Good morning. Welcome, Shri.
Good morning, Rupal. Can you hear me?
Yes, yes.
Yes,
very well.
Hello, everybody.
All the ones that you say I can hear. All the nice, not so nice ones I'm going to ignore and not listen.
It's so nice to be up on Sunday morning to see such wonderful, well-decked ladies. Congratulations to all your efforts in every way.
Some people have also joined on YouTube, and I think I'm going to start because that's
Yeah, I think, yeah.
So, good morning, everyone. There is a Sanskrit shlok which says, Gurur Brahma, Gurur Vishnu, Gurur Devo Mahesham, Gurur Sakshat Parabrahma, Tasmai Shri Guruve Namaha. So, Guru is a representative of all three, the Trinity, Shiva, Brahma, and Vishnu. And we salute to the person who gives you knowledge. And that's what we are going to do today, because we have amongst us the Gurus of Guru. We have the best in the field, and we are very privileged and happy to welcome all four of you, Dr. Ramamurthy, Dr. Chitra, Dr. Partha, Dr. Shri, for sparing such valuable time to join with us today. And without much ado, I think I will just start with the program. I'm going to first introduce the first speaker, and that's going to be Dr. Chitra. Let me tell you, all of the speakers today do not need any introduction because they are in their own right, as I told Chitra in the morning itself, self-illuminating. But just to give you a brief insight into their lives, Chitra is a very dear friend, a very cheerful, very helpful person with always an encouraging smile. She is there for everyone, anytime, and I've seen that and experienced that over a long decades of time. She's presently the chairperson of ARC of All India Ophthalmological Society. She was a member scientific committee for ARC. And she's been a much sought after speaker in a lot of national and international forums of repute. I've seen the efforts that she puts in after each and every talk that she gives. She tries to make it as complete as possible and as much that we can take home. She's been participating in a lot of instruction courses, not just in India, but also abroad. She's been a sought after speaker at the ACRS, APAO, APACRS, EACRS, you name the conference and she's there. She has many papers to her credit, both nationally and internationally. And I'm very, very happy to welcome you, Chitra, and to set the ball rolling. Please talk about surface ablation and we shall then go ahead. Thank you, Chitra. Please share your screen and stop sharing.
Showing host as disabled screen sharing.
Yeah, I will just stop sharing.
Oh, okay.
And then you can share. Is it now okay?
Oh, no, it is not. It's still disabled.
Oh, okay. I'll just allow that to happen. Just one moment. I'm making you the host temporarily because I can't find the other way.
But then,
just see if you can now share.
Yeah. Is my screen seen?
It is seen.
Okay. Thank you so much, Rupal, for such warm words of welcome. It actually energized me totally. And it was sort of a limiting thing for me that the whole of my travel for the elections, I somehow really wanted to come to Baroda and it got missed out. And I'm so glad that this opportunity came, wherein probably I'll end up meeting a lot more of you than I had come to just one small place. So without wasting time and keeping in view how meticulous Rupal and all of you would be, I'm going to go on to my talk, surface ablation. Please do stop me if I'm running out of time. Essentially, it was excimer laser invention and the surface ablations as the PRK, which opened up the realms of the refractive surgery. But at that point of time, the guidelines and the protocols were not very well defined, and it was temporarily stumped mainly because of the haze and the regression at not having the set ground rules. If you look at the growth graph both in US and Europe, you could see that right up to 2007, there was a climb of the femtoLASIK and the microkeratome LASIK. And then there came a resurgence of surface ablations and phakic IOLs in Europe. But what was also interesting was that a small group of eyes in the mild to moderate myopic range presented with iatrogenic ectasia. So this raised an alarm among the proponents of refractive surgery, and there was a more tempered understanding and some set ground rules were laid. So we all know that surface ablation preserves more tissue. It has an advantage in thinner corneas, and the dryness caused by surface ablation is milder compared to the flap-based procedures because it cuts fewer of the nerve plexus. It is biomechanically more stable because it goes without saying that vertical cut of the flap and the cut of the densely compact anterior lamellar fibers, which occurs when you're doing a flap procedure, is not happening with a surface ablation. More so with the advent of the modern laser technology, the smooth aspheric profiles and the flying spot lasers, which better address a higher order aberration. And most importantly, the epithelial mapping, which has now got added on to help us do a more precise PRK. However, having said that, it seems reasonable to think that we should limit corrections of surface ablations to 50 to 75 microns, ensuring that our cutoff is not more than -6 diopters. We should avoid using smaller optic zones because it has a propensity for regression and haze has also been seen even in lower myopic corrections. MMC, mitomycin, continues to be an off-label option, but interestingly, there have been reports wherein they have seen that there are less reports of ectasia in MMC-treated surfaces, but we cannot generalize on that. But there has also come an awareness that MMC does not actually deplete the functional reserves of the keratocytes. It only prevents hyperproliferation of keratocytes and prevents laying down of those irregularly generated material, which could cause scars, which used to occur in the earlier PRK procedures. So then surface ablation had larger ground to play on. It could be used for treating standard refractive errors in thinner corneas. If there has been a flap complication, it has been used as a retreatment option and as an enhancement tool or as bioptics procedure or as to regularize an mild keratoconic corneas and of course as PTK options. Now, these are any number of complications like a vertical breakthrough in a femtoLASIK. You would redo it with surface ablations, or an small eye which has had an inadequate flap, or if there has been a buttonhole, you would all allow the initial problem to be sorted out, be a partial flap or a free flap. You could put all these flaps back and then go ahead and do a surface ablation once the refraction and the topography settles. So there are multiple options, like even post-cataract residual refractive error, or if the eye is so small that a suction speculum was placed again and again, and finally you realize that you have a wonderful tool like surface ablations to treat. As far as the profiles of treatment, earlier we were doing wavefront guided options, but then came the wavefront optimized, and today topo-guided treatments have come to stand and has a major role play as far as surface ablations are concerned. However, understanding continued to evolve to improve PRK procedures. Like we realized that the epithelium should be removed from the periphery to the center. Either you do a mechanical debridement in alcohol, but you need to avoid excessive alcohol exposure. You should avoid overhydrating the cornea. You should avoid treating thinner corneas, avoid having lesser residual bed. And of course, transepithelial PRK seems to work even better if you have an epithelial mapping. So there were different ways it started off, like either you could do a LASIK procedure where in all these procedures you would irrigate with chilled BSS, and in LASIK you would place a trephine in which you would place 70% absolute alcohol for 20 seconds to loosen the epithelium, or you would use to do a decade back an epi-LASIK procedure wherein a mechanical plastic separator was used to bring about a separation between the basement membrane and the Bowman's membrane. Or presently what you do is a transepithelial PRK where a PTK mode, the epithelium is removed and then we go on to do the refractive correction. The earlier on, we were using nomograms wherein we would add a 0.5 for the hyperopic shift which would occur in a surface ablation. But today, if you have the streamlined PRK mode, there's an inbuilt algorithm in it which compensates by giving some extra laser shots in the periphery so that you do not need to alter your algorithms at all. Pain factor is a chilling feature of PRK. So you could use a chilled BSS earlier before you start the procedure, which would sort of chill the plain nerve endings. You could place ice packs for 15 minutes before the procedure, or you could place a BCL on after the procedure, which would protect the nerve endings, and as the epithelium regrows, some component of the pain could be dealt with. The main bugbear with surface ablation has been haze. And this has been largely seen if your refractive corrections are higher, if there is some reason where the epithelium is not healing well, if the epithelial surface is irregular, if there has been a damage which has occurred to the basement or the Bowman's membrane, or there has been an excessive exposure to UV light at different altitudes, or if you have not placed your sponge optimally on the corneal surface so that some of the areas are left unexposed. And haze could occur even as early as the first or second week and go on to up to 6 months. But today, we have much better solutions. We have better laser ablation profiles that I alluded to. Now we have larger optic zones which take care of regressions and haze adequately. And we have seen that alcohol assisted is better than mechanical, and transepithelial PRK works even better. Protective dark glasses to block UV radiation, use of vitamin C, use of topical steroids to prevent the aberrant healing responses, and of course, treating the dry eye status like with cyclosporin and plasma-rich growth factors. Mitomycin does not have only a cytotoxic property, but also anti-proliferative property, because of which it better addresses the haze, and it is time and dose dependent. And today, it has expanded its options to treat routine regressions, retreatments, post-PRK, and any other complicated situations. But in PRK, we need to be cautious that because of the need to use topical steroids for a longer time, some of them be steroid responders because these are young myopes. Again, if you've had a haze, it could be that it was an inadequately treated primary procedure. Then you could probably restart topical steroid drops, and if it's a very mild nebular haze, it would disappear. Or you could scrape the tissue mechanically or with a PTK mode and then place mitomycin, and of course continue treatment with topical steroids, which could take care. We also need to understand epithelium better. We now know that epithelium remodeling is based on the rate of change of curvature. So remodeling is so specific to the refractive procedure. In a myope, there is more modeling in the center and in the hyperope in the periphery. And we have seen, as I've been repeatedly reiterating, that if you have a larger optic zone, there is less regression and the refractive unpredictability is curtailed. But again, we also need to know that there is a higher variability of how the epithelium counter changes in a keratoconus eyes, which again is better understood if you understand the epithelial maps, and it thus becomes a differentiator to avoid treating these suspicious eyes. So which are the instruments which are ideal for epithelial mapping? The ASOCT and the high frequency digital ultrasound, which helps you to diagnose KC. It helps you to screen refractive surgical patients to understand whether there has been excessive epithelial hyperplasia in these eyes, to understand the post-refractive surgical complications, and also evaluate your CXL outcomes. Now I'm going to be showing you some topography maps. Now this was a routine refractive error, and what it needed a surface ablation to be done. So you look at the epithelial maps and it shows as average at 60, and you feed in the 60 micron and go ahead and treat. We've also come to understand that it just makes sense to lift the flap right up to the first 3 years where the propensity of epithelial ingrowth is less. Beyond 3 years, if you're doing enhancement, it is better to do a surface ablation, and because that is when the epithelial ingrowth occurrence increases. The topo-guided mode with the PRK seemed to be a way forward. As you can see, this was a very routine refractive error, a very old case where a microkeratome was used and treated elsewhere, wherein in one of our centers, wherein the corneal flap was not positioned properly, the limbus to limbus orientation was not there, because of which there was one excessively steep area and a flat area. So keeping the Zernike polynomials in mind and any refractive impact, you could just go ahead and flatten the steeper area and do a hyperopic treatment away to lift up the flatter area. And thus the corneal topography, if you can look, this was how the topography was, and this is how the topography becomes after regularization. And then the refractive error could be further treated after 3 months with a wavefront optimized mode. We also have started understanding biomechanics better, but yes, we are still limited in the way these tools are coming forward with the information provided. But of course, one thing we all understand, that cross-linking strengthens the cornea. That means regression and ectasia are evidences of weakening of the cornea. And if you could do cross-linking along with the surface ablation procedure, this seemed to go better. So of course, the initial fears of a progressive flattening with cross-linking or the refractive impact was understood that if you could keep your energy levels less, then you would do a standard cross-linking protocol. If you are able to treat those suspicious topographies and retreatments, keeping the energy at 2.7 and exposure of 90 seconds and effluence of 30 milliwatts per centimeter square, or some small variations depending on the comfort level of different surgeons. Mitomycin is definitely used when you're doing cross-linking because it prevents the migratory keratocytes from creating any haze. Again, form frustrate keratoconus came into the ambit of PRK with the essential concept that the central myopic, that steep area because of the keratoconus can be flattened, and the peripheral flatter area is lifted up by doing an hyperopic ablation, so that you end up having a larger, smoother area, which is not irregular, which could better withstand the biomechanical strain of the intraocular pressure in the eye. Then there were scores of papers which came forward to tell us that topo-guided PRK with cross-linking seemed to be way to go. But then it also made sense to do the treatment simultaneously. Now, why simultaneously? It can't be that you have cross-linked the cornea and then later do a surface ablation procedure for the regularizing the topography. Then you would have removed some cross-linked cornea. Again, it also we need to understand that if you're doing laser on a cross-linked cornea, our laser algorithms are not tuned to how a cross-linked cornea would behave, more unpredictable. So keeping this in view, doing a simultaneous topo-guided treatment and then cross-linking and locking the treatment seemed to be the most efficient way to go. Again, if you could do a PTK mode of laser removal of the epithelium, it would remove the epithelium and stroma in a uniform fashion, and that itself would smoothen the corneal counter, and then go ahead and cross-linking seemed to be the way to go, as was better understood. So then a little more on topo-guided PRK in form frustrated early keratoconus, mild keratoconus. Now you can see that the patient had an uncorrected vision of 636 with a asymmetric bow tie and a decentered cone. If you were supposed to only do not do a refractive correction and just regularize the topography, you need about 27 micron of the tissue. But if you feed in some amount of myopic correction and the significant amount of the cylinder, in other words, keep in view that about 70% of the correction, if the corneal thickness allow is treated, you can take a call whether you're going to use the topographic axis or the refractive axis based on how your plan of ablation pattern coincides with the anterior float topography. And then you go ahead and cross-link this eye in a standard cross-linking protocol, and the patient gets an uncorrected vision of 6 months. This is again another case with a high cylinder in a similar modality. Only thing, you can bring down your optic zone to 5.5 so that you'll consume less tissue. And this is how you can look at how the plan of topo-guided treatment coincides with the topography of the anterior curvature, anterior front. And this is how the topography improves. Again, in a post-LASIK, 6-12 parts vision, if you're able to treat this, and if you look at the topography which is planned, it coincides with the tongue-like projection in the anterior corneal float, and you are able to debulk significant astigmatism, and you're able to optimize the vision to 6-9 parts. So and the last but not the least, newer algorithms like 4 series algorithms came in to treat topo-guided PRKs, wherein we came to understand that a refractive correction should not be doing what is correcting just on the anterior corneal plane. We need to consider the posterior corneal astigmatism. We need to look at the internal optics. And he came in with a vector analysis, and he would the formula would feed in the data which would need to be corrected. And thus, with the PRK, we were able to incorporate different treatment profiles and newer vistas of laser vision correction. So yes, I would like to conclude stating that surface ablation is to be remembered as a major portfolio in the refractive armamentarium. Yes, it has a longer recovery time. We need to have realistic expectations, but yes, it has come to stand finally. Thank you very much.
Thank you, Chitra. This was superb because it covered almost everything. And we will keep the discussions at the end. Our topic for today is spectacle free from 18 years to 80 years. So we are going to right now in the first session deal with the younger lot who are going to undergo a corneal refractive surgery. And then in the second session, we'll go on the lens-based methods. So surface ablation was the one which came into being right in 3 decades ago. And it has still stood the test of time, and it's coming back with a lot more refining, as Dr. Chitra already pointed out. So that's why it's important to know and also learn this technique, because this is a very useful technique in the armamentarium. But Chitra, you really made it very difficult for Partho because it seemed as if that was the way to go. So I'm going to now introduce our next speaker. And that's none other than the current AIOS, the Scientific Committee President, Chairperson, Dr. Partho Biswas. Let me just share his biodata with you. So more than anything, I have really admired Dr. Partho for his rare sense of humor. So there are people who are as accomplished, probably but also having the same background, but something that really differentiates Dr. Partha is his sense of humor and also his deep insight into everything that he does. He's an iconic personality who has won many awards and accolades at national and international platforms. He's reviewer of many journals, multiple publications to his credit. He's an international speaker, but I'm not going to speak much more because otherwise either he'll sue me or I will get court-martialed. That's what he is known for in ophthalmology. A postgraduate teacher and evaluator, a guide to several young ophthalmologists, and a real pleasure to listen to. So Dr. Partha, I would really want you to now share your screen and please take the floor.
Thank you very much, Dr. Rupal. And it's always a big pleasure to be associated with your webinars, your conferences, your CMEs. And as usual, you make it so difficult and so intriguing. And especially you put me after Chitra to speak. So Chitra has spoken so well, so elaborately that I really don't know where I'm going to stand. So all the time that she was speaking, I was deleting my slides. So now that I have deleted most of my slides, I have just a few slides for you to share. And this is a very important topic that you have taken up. And right from the surface ablation to the microkeratome LASIK to the femtolaser and the smile, that is going to be the vista of the laser vision correction. And then we definitely go on to the next part of the session, which again deals with the next group of our subjects, that is the elderlies, where we give freedom of glasses. If I have to go on to the microkeratome LASIK, and if this microkeratome LASIK is something that we have to see, so the microkeratome LASIK as it is, 1 minute, please. So it is, we come up with all these young men and women who say, I just don't want these glasses. And for them, what do? We have these solutions for refractive error, the glasses, the contact lenses, the refractive surgery, and we also have the ICL, the IPCL, the lenses which take away the refractive error and give a vision without glasses. Now, just going into a small bit of the history, which is very important for all of us to remember, the radial keratotomy by Sumoto Sato in Japan in the 1930s, and in 1950s and 60s, we saw keratomileusis, and Jose Barraquer was the wonderful worker who actually gave us keratomileusis. In the 1970s, the excimer or the excited dimer laser and its medical use was discovered by Stephen Trokel and Dr. Srinivasan in the early 80s showed how it could be used in the human eye. In the 1980s, it was Margaret MacDonald who was the first to perform the surface ablation. But LASIK was patented by Ghulam Peyman, and the first publication in LASIK in patient care was by Ioannis Palikaris. So these came on, and LASIK was one great area that dominated the refractive surgery for the last 2 decades. Of course, LASIK gave us the wow factor that PRK would not give, and the LASIK changed the refractive power of the cornea. It created the hinged corneal flap with the epithelium and the Bowman's membrane and the superficial part of the stroma. The more posterior layers of the stroma are now exposed to the ablation, and for myopic treatment, what we do is to flatten the central part of the cornea, and the refractive error of the eye decreases to attain ametropia. For the hyperopic treatment, of course, the paracentral areas are flattened and the steeper central cornea has an increase in the refractive power. So right now, the myopia that we can treat is 0.5 up to -9. However, most of us do not do over -8, but at times when there are certain conditions, even up to -9 can be treated, but these best be left if it is not really required by laser vision correction. Hyperopia up to +4, +5, or +6 also some of us do treat. Astigmatism we can correct up to ±5 diopters. The contraindications for LASIK is the refractive instability. So what is very important is to ascertain whether the patient is refractive stable over the last 6 months or over the last 1 year. And this will give the right correction of laser vision correction. The corneal ectasia is a very important parameter, and we need to check it out by the pentacam. Keratoconus has to be taken off, and uncontrolled systemic diseases. And these diseases are important, and a good history taking is very important in a LASIK workup. Any active infection of the eye is important and has to be attended to. Herpes zoster, herpes simplex, keratitis, cataract, if it is there, has to be ascertained well and with a dilated pupil. Glaucoma has to be ruled out, and corneal dystrophies have to be ruled out as well. The preoperative considerations are important, and just to reinstate some things that we all know and we all practice. However, the contact lenses, and most of our myopes do wear contact lenses, should be discontinued for a week or two in advance to allow the corneal surface to stabilize and give more accurate measurements. The history and the physical examination has to be completed, and any identifying points for contraindications to LASIK has to be ascertained. The visual acuity testing and the refraction. And here I would like to say that it is very important that the patient be aware of the best corrected visual acuity that the patient has, and has to be told that this is your final vision, this is your best vision. Otherwise, what happens is post LASIK, certain unrealistic expectations crop up, and the patient is not a happy patient despite a fantastic correction. So this is important. Refraction, and that at times cycloplegic refraction needs to be done if one is not sure that the patient has a lot of cycloplegic aspect that has to be taken care of, and the refraction has to be good and stable over time. Slit lamp examination, fundoscopic examination again is very important, and any treatable lesion of the retina needs to be treated, needs to be taken care of, and needs to be documented, because such patients need to have these retinal examinations, fundoscopic, dilated, indirect fundus examination over the time. And it's just not for LASIK, but also for the lifetime of these patients. Dry eye evaluation, Chitra has already alluded to, and it's very important. And also is important the intraocular pressure. The intraocular pressure has to be taken care of. It is important that these myopes at one point of time in their lives can develop glaucoma, and the cup disc ratio, and in this fundus photograph is possibly important, and any patient with a suspicious disc definitely should undergo perimetry evaluation. Most of the time they will be within normal limits, but let us remember that as we change the thickness of the cornea, the evaluation of the intraocular pressure becomes even more important in the later years after LASIK. The cornea is evaluated by keratometry, pachymetry, and the corneal topography is to be done. The preoperative considerations, the Munnerlin's formula to calculate the ablation zone and the depth of the LASIK treatment. And this incorporates the thickness of the tissue that is ablated, the diameter of the optic zone, and the dioptric correction that has to be given. The pre-surgery is very important, and not only the pre-surgery, but also the pre-surgery techniques are dependent on the previous day's post-surgery protocols, which are very important, and especially for the maintenance of the microkeratome, which is an important tool, and the cleaning of the microkeratome after a surgical use has to be reinstated time and again, and has to be cross-checked and supervised at times for the technicians who usually perform them. So all equipment should be checked for safety. The topography data is imported into the examer. The patient should be given education about the procedure. Let us remember that for the patient, it is the first time procedure, and it's important that the patient understands that these are the steps that are going to happen, because again, the cooperation of the patient, as we all know, is the most important thing in the laser vision correction. So what to expect of a laser vision correction of the procedure needs to be told, needs to be understood by the patient before the patient walks in to the operation theater. The preoperative antibiotics, usually not 3 days, but a day in advance is usually started. And as of now, the povidone iodine preparation of the surgical site has become mandatory, important in these COVID times. and we instill povidone iodine into the cul-de-sac, which we never did previously because of the fear of DLK occurring. But what we definitely do, and what is being practiced in these COVID times, is at least 10 minutes before the surgery, while the patient is in the waiting room, to instill a drop or two of povidone iodine into the cul-de-sac, wait for that 10 minutes while the patient is getting prepared, and then a very good irrigation before doing the LASIK is mandatory. So with all this, counseling is the most important part, and it matters most. The optometrist needs to counsel and the doctor needs to counsel, and each counseling, the chair time given is very, very important to the patient. So the workup before the LASIK procedure is important, and the green signal has to come from the ophthalmologist before we go ahead with the laser vision correction. The eye tracking systems have come in, and they minimize the decentration, and a minimal of stromal bed drying is required because of the fastness of these lasers systems that we have now. It removes, the EX500 removes about approximately 1 diopter in about just about 1.4 to 1.5 seconds. So these are very fast lasers that we have today. EX500, again, this is the laser that we use, no financial interests here, but corrects the minus power as high as minus 12 diopters and a plus power of plus 6 diopters, and cylinders also can be taken up very well. Removes approximately 12 microns to correct 1 diopter of power. So the preparation in the OT is important, and the surgical technique is actually quite simple. Once we have the patient on the couch and rested, what is very, very important till today is the marking of the limbus, and that has to be a paracentral marking. We use the Morea microkeratome, which is an excellent microkeratome, and it's very important that we definitely adhere to the protocols given by the manufacturer for the ring size. And it's a very quick process. The patient is usually quite comfortable during the process. And we have a microkeratome section of the cornea being made. The cul-de-sac is then very nicely swabbed so that there is no extra fluid. Otherwise, this would go in and into the laser area and would undercorrect the ablation. The flap is nicely lifted out. The flap it is important that the hinge be off, and usually this is what we do. We half lift it and we cover the hinge with the epithelium part of the edge so that it is just half folded. The laser vision, the vision correction is a very, very fast process, and usually the patient is very cooperative during this whole process. It's important to keep talking to the patient at this point of time, and the patient is supposed to look at the fixation light, which usually they are able to cooperate very well. So once the process is over, it's usually placing in the BSS, usually a chilled BSS on the stromal bed, and then the flap is reposited back. It's very important when a large number of cases are being taken up, not to hurry in this part where the drying time is again a very, very important phenomena, and to avoid any of the wrinkles post-operatively or any of striae that can come in post-operatively. So this part is important, and we usually have the slit lamp part incorporated into the laser machine, and that's a very good attribute for these laser machines, where we can check on the stroma as well as the apposition of the flap. So post-surgery, the patient instills preservative-free artificial tears because the eyes are dry, and this is a common side effect of the surgery. Antibiotics are given for 2 or 3 days, and steroid drops for 3 to 5 days after the surgery, and after that it's just lubricant. It's important and imperative to check these patients after the surgery and to be very sure that they have a good vision and they are satisfied. The wow factor is there even just after the surgery, and the patient can see quite well, usually is overjoyed in such times. So let us now look at the lesser happy things and the complications. Dry eyes, Chitra has already said, the visual aberrations can be there, and the visual aberrations at times are quite disconcerting. However, with the ablation profiles of the recent times, they are much better. Diffuse lamellar keratitis again has nearly disappeared, but still can come on. So it's very important to pay attention to all the protocols of the laser vision correction and the maintenance of the microkeratome. The corneal flap complications I'll just deal with. Post-classic ectasia and infectious keratitis, we will just go ahead and look into the flap complications. Now, I want to share this video, and though it's not a very high quality video, it's a very important video because it shows that I had this flap complication, and look, we had a free flap, and how the free flap is to be restored is very important. This is the microkeratome, the Moria microkeratome, and the free flap is usually rested in between the blade and the space between the microkeratome and the blade. So the right side up is the most important aspect that each one of us need to pay attention to. So what is required at this point of time when you have discovered that the free flap is there, to put a little bit of BSS to moisten the free flap and let it be housed in the blade holder itself. Go ahead with the laser vision correction, do off the laser vision correction, bring the microkeratome in toto across right near the limbus, and then very gradually just simply float out the flap here, as you see, onto the bed of the cornea. So once this is done, so once it is there on the bed of the cornea, the unfolding is pretty simple because you know that which is the right side up. Because if the flap becomes boggy or if the epithelial surface becomes abraded, it at times becomes quite difficult to understand which is the right side up. The other important aspect is the importance of the marking, and you can see that these markings are imperative and have to be there so that the position of the flap can be very, very accurate. It's important to be very tender in these aspects, and of course, not much of exchange of conversation should go on in the OT, though it is a very, very high tension time with a flap that has been made into a cap, and everybody is aware of the difficulty of this situation. However, the smoothing of the cap over the bed is important. The drying time should best be 5 minutes. Let it dry for 5 minutes with a little bit of BSS in the center of the pupil and put in the contact lens. Let me share with you another of the flap complication. This is shared by a good friend of mine. And what happened is the microkeratome went across and came back. And in between, what happened is this. So this is what she saw, and immediately she understood that what she had missed was EBMD. So the EBMD which she missed out, and thus the EBMD as actually is important, but it is only the epithelium that is messed up, and the bed actually is very, very well formed, and therefore all that you need to do is to go ahead with the laser vision correction and replace the flap over the bed. It's of course important that the epithelium has been denuded, and this epithelium usually, if it is a large epithelium defect, it can be taken off or snipped off. Of course, the patient did not, my colleague did not do the second eye of this patient, and the patient's second eye underwent vision correction with the femtolaser LASIK. Now, this is another case that we would like to share with you. And here there was huge amount of epithelial ingrowth. The flap was gradually disintegrating, and we had to take off this flap and remove the whole flap and remove the epithelial ingrowth from the bed, and mitomycin C was placed, and then a BCL was placed. There was haze for nearly 7 to 8 months. Gradually, it disappeared, but there is still a haze even after 3 years, and but this could not be helped. The patient had a drop of the best corrected visual acuity by 2 to 3 lines. Let me show you this problem that we had solved. This was a patient with a surgery elsewhere, a microkeratome problem, and was referred to our center. So this is what when the patient came with. So the primary surgeon said that he had created a flap, but it was an irregular flap, so he just had let it across and had sent it to us. So when we saw this was the situation, and we started the patient on topical steroids, didn't know much what to do because we thought that there was epithelial ingrowth that was growing already. So then this was the situation, and when we stained the eye, this was the stain that it took. So there was a large area that took a stain which was beyond the edge of the flap. So what was this? We were really perplexed. So the patient comes back after 3 days where there was a huge amount of eye pain, and this is what. There was a roll of this whole epithelium that was there. And what had actually happened is the free flap had dislocated and the epithelium had grown across, and it was just stuck to an edge over there. So this is what it appeared to be. As you can see that most of the pupil is spared. So what was all this? So what we lifted it out, and since we could see that it was a free flap with a lot of epithelial ingrowth, we just removed this free flap, and we put in bandage contact lens. The patient attained about 6/12 vision in about 8 days. Of course, we waited for this patient and did a laser vision correction nearly after 3 to 4 months. This is the last complication that I must show to you, and this is again nearly 15 years old. So my friend, a colleague who said that, I did a microkeratome LASIK, and that was a free flap, and I placed it on, but now the next day, the first post-operative day, what he saw is the flap was not there when he was checking. He had said, and this is what, when the patient came to us, this is what was the situation. We looked at the slit lamp, and what we could see is the flap was there rolled up at the inner canthus, very, very perched very tediously over the inner canthus, over the lid. And the patient was watering. There was a lot of irritation, but it was God's grace that the flap was there. So what we did is we took it up, and we reposited the flap. Now, after 3 days, it was not doing too well, and so we stained it, and this is what we saw. We had made a green chapati of myself. I had made a green chapati of myself, and this was it. It was an upside down flap, as you can see it. So back again, and you can see that at that point of time, I was not using gloves because we did not have powder-free gloves at that time. So took off the sutures and replaced it back again, the right side up. And over 3 months, the flap gradually settled, and the flap and stroma lived happily ever after. Thank you very much for your patient hearing.
Thank you, Dr. Partha. Truly, some of the things that you showed was really horrifying. So, but we all know it doesn't happen that often. But if you want to avoid even this rarely occurring complications, we now have surgical advances. We have tools to our aid. And discussing with us today about the femto LASIK is none other than Dr. Ramamurthy. Dr. Ramamurthy, it has been always an inspiration for me. he is somebody who is whom I have admired and also respected throughout. He is a chairman of the Eye Foundation, which is a chain of 10 tertiary care eye hospitals across India. He's been the chairman, Scientific Committee, All India Ophthalmological Society for 6 long years. And he was also the president of the society in 2016. So we have not just a past chairman, Scientific Committee of AIOS, but also the present chairman, Scientific Committee, and maybe the future one. He's been awarded many national and international awards and orations. He has authored 26 publications in peer-reviewed journals. He's been invited for many conferences. He's even wrote 8 textbook chapters. He is the recipient of the Distinguished Service Award from APAO and also the Asia Pacific Certified Educator Award from APS-CRS and the Achievement Award from AAO. I personally know him as a wonderful teacher and an even better human being. Thank you, Dr. Ramamurthy, for being present here today. And please share some knowledge with us today about femtoLASIK and of course later on about other things. I also have some questions for all the participants, so we should just wait and also have the question answer session at the end of this particular session and then at the end of the next session. So Dr. Ramamurthy, please.
Thank you so much, Dr. Rupal, for that very kind introduction. Truly obliged to the President, Dr. Rupal, as well as the Baroda Ophthalmic Society for this very kind invitation to participate in today's webinar. I know most of you personally, and it's truly a happy occasion to connect with you all, though virtually. Looking forward to the days when we can meet in person once again. After those 2 beautiful talks on surface ablation and microkeratome LASIK, it's my premise to take you on to the next level and talk about femtoLASIK. What exactly is a femtolaser? It's a neodymium glass laser, which operates in the infrared wavelength range of 1053 nanometers. And it's an extremely small pulse duration of 10 to the power of minus 15. It's supposed to be 1 millionth of a billion. It's supposed to, there's a term called quadrillion. And why exactly do we need it for such a short time? Basically, the total amount of energy that is transmitted onto the cornea is determined the power into time. And when we need a certain amount of power without causing collateral damage, without causing heating of the adjacent tissue, we want it for an extremely short period of time so that there is the laser does what it is expected to do without causing any kind of deleterious impact on the adjacent tissues. And that's the reason the femtosecond laser is of such a short duration. As most of you are already aware of, what it actually does is to create a microplasma of just about 1 micron in diameter, which gradually expands and creates a plane of cleavage. There are thousands and about billions of shots which are fired in adjacently, and this creates a plane of cleavage. And this can be in the horizontal orientation, it can be vertical, it can be oblique, and that's the reason it's an excellent cutting tool. As far as the exploration of femtosecond laser is concerned, whether it's in the realms of refractive surgery or cataract surgery, I believe we are just exploring the surface, and maybe in the times to come, it's not just in these 2 fields, but in various other fields of ophthalmology also, it will find a significant application. There is a understanding that we have to have about the amount of energy as well as the frequency. Basically, the action of the femtosecond laser is dependent upon the pulse duration, the energy in the pulse, the distance between the pulses, and as well as the duration of each pulse. Well, when we started out with the laser, we got it, I think, one of the first femtosecond laser way back in 2007. It was an intra laser, and mind you, it is still in use with us. It was a low frequency 60 hertz laser, kilohertz laser. And that's the reason it had created a fairly large spot, and it used to have a significantly higher energy in the range of about 1.3 microjoules. But on the other hand, what we do have today is a Visumax, which is of a much higher frequency of about 500 kilohertz. That's about 4 times. And similarly, the pulse energy has gone down by about 4 times. That's in the range of about 300 nanojoules, because of which there's much faster recovery, less inflammation, less haze, and less incidence of transient light sensitivity syndrome. When initially the femtosecond laser came in the iteration of 6 kilohertz and 15 kilohertz, that is even before it became commercially available, one of the strong arguments against it was that the amount of inflammation it caused was much higher than what was being experienced with the microkeratome LASIK. Now with faster lasers, lesser energy of power being power being used, lesser amount of energy being impacted onto the cornea, the cutting is very gentle, and you find that most of these corneas remain quite pristine on post-operative day 1. As in most cases in ophthalmology, we are spoiled for choice as far as femtosecond lasers are concerned. We have the IFS laser at 150 hertz. We have the Visumax as well as the FS200 from the Alcon platform. Mind you, all these machines are good. There are variation, there are differences between them. But once you experience them, once you have gained reasonable expertise, I find that all of them do their job of relatively safe, good flap cutting. The point I want to make is, irrespective of your commercial affiliations, it's better to go ahead and buy any one of these that you desire, depending upon what exactly is the cost at which you get, the kind of support you get, because I think all of them work reasonably well and give you good flaps at the end of the day. As far as the laser settings is concerned, I'm not going to go into the details of pocket, hinge, flap bed, side cut parameters, etc., because these are all got to be customized for each and every laser, for each and every center, so that it performs optimally. But suffice it to say that the various patterns of laser delivery, one is the raster pattern, which is what the intralaser has, where there is a horizontal passage of the laser beam from one direction to another. Then you have the centrifugal pattern, where it comes in from the center to the periphery. Slowly the laser burns, enlarging in a circular fashion. And more often used nowadays, as in the Visumax, is the centripetal pattern, where the laser delivery actually goes on from the periphery to the center. And I believe Dr. Rupal Shah had a significant role in the evolution of this particular pattern. And truly, the smile per se owes a lot to the initial exploration as well as the conviction with which Rupal adopted this technology and made it available to all of us. Just to show you a simple procedure of the femto LASIK being done, it's actually a real-time procedure, and hardly any editing has been done except for the shifting of the patient from the femto platform to the examiner platform. This is with the Visumax. That's the docking being done, and basically the centration depends upon the centering at the limbus. Even a little bit of decentration does not matter, very little bit, simply because you're creating a bit. The actual correction is taking place in the femtosecond platform with the examiner laser. That's the outside-in carousel that's occurring, and that's the basic cutting of the flap, and subsequently the flap edge being created. And this is essentially the opening, lifting up of the flap. And this is exactly the time duration it takes to do the femtosecond flap. Many of you might be doing it regularly, and as you know, you could either score the edge right through, or I find it's quite adequate to just open it up in about a couple of clock hours, then gently lift it up, and what you get in extremely pristine, regular corneal stromal surface, which can go ahead and that's the laser being applied. No, it's again, now I'm just focusing it on the center. Both the red dots have to come together. The patient is asked to look at the green focusing dot. And subsequently, you always cut wet and ablate dry. That's for the microkeratome. It's important that you ablate the stromal surface before doing the ablation. And you dry up the stromal surface before ablating. And that fuzziness that's developing is because of the corneal tissue being removed at submicron accuracy. Each laser shot just removes about 0.25 microns of tissue. That's the reason, whether it's topo-guided ablation or whether it's femto LASIK or any other form of even a presbyon treatment, you are able to get an absolutely exact reorientation of the corneal tissues the way you want and perfect correction. So the marriage of these technologies of creating a flap with extreme control and accuracy, and subsequently reprofiling the corneal surface, most often translates to excellent visual outcomes. And basically, it's not excessive washing that you do. It's just a little flushing of the corneal surface, the stromal surface, putting the flap back. And essentially, what I do is to keep the surface moist and dry out the edges gently. The conventional teaching is to wait for about 2 minutes for the surface tension as well as the endothelial pump action to make the flap adhere back. But today I find that it's not really absolutely necessary. It just dry up the edges and then let the flap adhere back. And usually on the first post-operative day, what you have is a pristine cornea. That was a femtolasic procedure that went off quite well. But as we already see, the distance between the laser shots is, the femtosecond laser shots is extremely important. If the energy is too much or the shots are too close to each other, if this is the cavitation bubble that is being formed, and if the next laser shot hits within this cavitation bubble, it's not going to have its effect, the exact effect, but it is going to result in excessive generation of unnecessary bubbles, which is essentially leads on to the hard OBL. We'll be seeing a video on that. On the other hand, if the distance is too much and there's no overlap, there are uncut tissues that are left behind, and this leaves behind to again a difficulty in lifting up the flap, and that's a soft OBL or the slow OBL that we are familiar with. Basically, you can see this going ahead of the laser firing itself. This is a typical case of a hard OBL. Here, basically, the laser separation does not happen, and that's the reason in this area you would have a significant difficulty as far as lifting up the flap is concerned. This is essentially indicates excessive energy being used, and these situations is important to reduce the spot separation or the total energy that you're delivering on these eyes. It is also said that the older patients and the smaller and steeper corneas, where there is the collagen fibrils are more densely packed, there's a greater propensity for the hard OBL to occur. As far as the other situation is concerned, this is the soft OBL that we are talking about. Here, basically, the amount of energy is not adequate, and you can see these small white spots that are over there, and you can see also these dark spots. These are areas where essentially the fibrils have not been cut. Here, this is a situation where you might have to bring the spots a little closer or slightly increase the energy. Basically, these are not definite numbers for each center, for each surgeon, for each machine. There are certain settings, and with the help of the laser technicians who are extremely well informed, you can often optimize your particular machine to function very well and get the kind of flaps that I showed in my first video. Going on to the differences between the microkeratome flap and the femtosecond laser flap. Mind you, I think each of them have a place, especially in our Indian conditions. We have about 5 of these machines, and we do microkeratome LASIK, though the numbers have been constantly dropping. There is a femtosecond laser, and of course, we do SMILE also. And I do believe that depending upon the requirements of the patients and their ability to pay, we must have access to all these technologies. As far as the microkeratome laser is concerned, it creates what's called a meniscus flap. I'll dwell upon this a little more. And because of which there is a greater propensity for spherical aberrations, higher order aberrations. On the other hand, the femtosecond laser creates a planar flap, which is extremely smooth and regular from the center to the periphery without the variation in the thickness of the flap. The flap hinge and the diameter is keratometry dependent, whether it's steep or flat cornea that you're dealing with when you're doing it with a microkeratome. But in femtosecond laser, it's a 4 millimeter or a 4.5 millimeter hinge, and the hinge angle also predetermined, and you exactly get what you need. Even more importantly, when it comes to flap thickness, as far as the microkeratome is concerned, it's extremely dependent on the initial thickness of the cornea. Thicker the cornea, greater the thickness of the flap that you get. Thinner the cornea, the thinner the flap that you get. Where also there is a tendency for reusage of these blades, and every time you reuse the blade, the flap thickness is supposed to go down by about 10 microns. On the other hand, the femtosecond laser, the flap thickness is anatomy blind, whether it's thick or thin, or whether it is irrespective of the curvature of the cornea, you get the kind of thickness that you get is quite repeatable. The thickness predictability as far as the standard deviation is concerned is supposed to be in the range of 15 to 30 microns. With the intralace, it's more in the range of 10 to 12. I believe with the Visumax, it's more in the range of about 5 microns, which means that the kind of flap thickness that you get is exactly what you need. As far as the side cut is concerned, it would become more evident in subsequent slides that I show. It's somewhat shallow angle. It's more in the range of about 30 to 45 degrees with the microkeratome, because of which there is a greater propensity for epithelial ingrowth. On the other hand, with the femtosecond laser, you can either get a vertical or even obtuse orientation, and that's supposed to predispose to a better fitting of the corneal flap onto the edges, and that's the reason the tendency for epithelial growth is supposed to be less. As far as the complications is concerned, Partha already showed very nice videos of the various flap complications with the microkeratome and how we handle them. Free flaps, buttonholes, irregular flaps, epithelial aberrations, etc. Femtosecond lasers have come with a different set of complications, though many of these more serious complications are just not there when you're creating a flap with a femtosecond laser. We will look at some of these complications in the subsequent videos. As I mentioned earlier, as far as the orientation of the flap itself is concerned, sorry about that. I never knew that I had to click it so many times. As I said in the microkeratome flap is thinner in the center and thicker in the periphery. Of course, this is a somewhat of a magnified image of what you get. But suffice it to say that the flap thickness is not quite uniform. And again, more importantly, it depends very much on the anatomy of the cornea that you are dealing with. On the other hand, with the femtosecond laser, it's essentially a planar flap that you get depending upon the thickness you set, whether it's 110 microns, 100 microns, you get exactly what you desire. One of my indications, especially in my earlier days for a femto flap, was creating thin flaps. Whenever the corneal tissue availability was an issue, I used to go ahead and always stick to a femto flap for the simple reason that I could go ahead and create a 90 micron flap and be sure it's going to be 90 microns and nothing less. In a microkeratome, because of the variability, I generally do not have the confidence to create something less than 120 micron flap. And in case you get a thicker flap than what it was intended to be, obviously the flap bed thickness that you leave behind is lesser than what it was intended to be. As far as the orientation of the edge is concerned, with the microkeratome, this is what you get. And that's the reason there is a greater propensity for epithelial ingrowth. On the other hand, femtosecond laser, nowadays I generally set it at 90 degrees, but you can also have it in an obtuse angle like this. And this was for a certain period of time, it was extremely popular and talked about. This was said to be something like a fitting of a manhole cover. And that's the reason it was said that it would predispose to lesser tendency for epithelial ingrowth. I think a vertical orientation of flap edge also functions equally well. The fact that the thickness of the flap, the regularity of the flap that you create also translate to the fact that you get an extremely smooth bed, which is amenable to laser vision correction. And that is the reason that the tendency for induction of higher order aberrations, residual power, etc. is somewhat less with the femtosecond laser compared to a microkeratome lasing. As far as the apposition of the flap itself is concerned, it has been well documented. It's much better with the femtosecond laser compared to a microkeratome laser. And that's the reason the tendency for flap slippage as well as the microstay is somewhat less. This is just a video. As you can see here, the microkeratome flap being lifted 8 years later. You can see the ease with which I am able to lift up these flaps. And even 8 years after the initial treatment being done. But on the other hand, when it comes to a femtosecond flap, you can see that even 9 months after the initial treatment, there's significant amount of dissection that I have to make. Even the separation of the edges of the flap becomes a little difficult, and the tendency for it to adhere is much more. Obviously, when you do a retreatment, it's a bit of a challenge, but that's not something that we commonly do. But it gives us the advantage that the tendency for microstriae, flap slippage, etc., is much less with the femtosecond flap compared to a microkeratome flap. As far as the anatomy of the cornea itself is concerned, when you have a steep cornea like this, a 47, 48 cornea, I would insist on a patient going ahead with a femtosecond flap, because as you can see in this, when it's created by microkeratome, you can get something like a buttonhole. And obviously in these situations, we have no other choice but to leave the flap back, wait for a period of about 3 months and redo the treatment, maybe a surface ablation in this case. Again, if it's a flat cornea, as was shown earlier, this can result in a free flap. You can see it's a 41, 40 cornea. And in this is again an indication for using a femtosecond laser. These are the situations where, irrespective of the patient's ability to pay for it, I would insist on a femtosecond flap in case a procedure has to be done. Again, when you're using a microkeratome LASIK, it's predetermined as to where you get the hinge. With the Hansetome, it's superior. With the Moria, it's temporal. But with the femtosecond laser, depending upon the anatomical considerations and the requirement, you can exactly position the lens where you want, even in the oblique direction. Coming to some of the complications that are easily handled with the femtosecond laser, this is a situation of a suction loss. Actually, it's an advantage. If you have a suction loss during a microkeratome procedure, you have no other choice but to postpone the procedure, go back about 3 months later. But if you have a suction loss with a femtosecond laser, as in this case, all you have to do is to redock again, make sure there's no movement of the patient's eye. You can use the same PI, and that's, you can see 2 levels at which the ablation has occurred, but it's easy to lift up these flaps and go ahead and complete the treatment. So suction loss is really not a great disadvantage. And just in case it has happened right in the end, as it happens in this case, you would find that almost the entire treatment has gone off well. I'll just fast forward this. It is just right at the end that I have some difficulty as far as lifting up the flap is concerned. So all I do is to just repeat the side cut only after reducing the overall diameter by 0.5 millimeters. There's a bit of a resistance, but I'm able to go ahead and insinuate the instrument behind the flap and lift it up and complete the treatment. So when you are using a femtosecond laser, even if you have a suction loss, as far as you understand and follow certain basic principles, you can go ahead and complete the treatment in the same stage. And some other challenges which are unique to the femtosecond laser, a vertical gas breakthrough that essentially occurs when the scars in the cornea which does not allow the laser to pass through. And these are thinned out areas, and when the pressure of the air bubbles build up, sometimes it gives way. And the other problem, which is really not much of a problem, is the bubbles in the anterior chamber. Let's just to look at 2 videos doing this. This is a nebular opacity that's over here. As you can see, the femtosecond laser passing, there's already a very dense hard OBL. This gives way over here. If it was right in the center, I would have had no choice but to postpone the case. Because it's in the periphery, we could actually lift up this flap and go ahead and complete the treatment. This is just a situation you will see that the gas bubbles go through the trabecular meshwork into the anterior chamber, and that's just in case it's significant. All you have to do is to wait for this for about 3 to 4 hours to disappear. Only thing is it might interfere as far as the tracking of the eye is concerned. And you can see over here, these are the gas bubbles in the anterior chamber. Seriously, it does not interfere too much with the laser delivery per se, and you can even complete the treatment at the same time. Just to show that whether it's a eyelash or whether it's some kind of a debris on the surface, here you see over here. And in case you do not are cognizant of the fact that it is there and go ahead with the laser treatment, once it has started, you do not have the mind to actually discontinue the treatment. Obviously, here no laser treatment would have taken place. So there is a significant amount of dissection that needs to be done here to lift up the flap. Of course, it is possible, but it's not really very nice to see. So it's important that you ensure that there is any interference in the laser passage is not there. Plenty of studies which have been there, at least in the initial period, comparing microkeratome LASIK with femtosecond LASIK. And now it's all in all history. and it's well established that femtosecond LASIK is a better way to go, because though there is no significant advantage as far as the visual outcome 6 months to 1 year later is concerned, as far as the predictability of the flap thickness, getting a planar flap, the centration of the flap, getting the right size of the flap depending upon the what kind of refractive error that you are treating, and avoiding serious flap complications, femtosecond laser definitely scores over the microkeratome flap. But friends, the flap is still a flap, and conventional LASIK you have, bladeless LASIK you have, and of course we have the Queen of Smile sitting right over there, who has really been a forerunner as far as the smile technology is concerned. And let's wait to hear from the more about it. Thank you so much for your kind attention.
Thank you so much, Dr. Ramamurthy, for putting the femto-LASIK in perspective, showing all the advantages, also the limitations. It also shows that when you are using any tool, it's not just the tool, but also the man behind the machine who actually is responsible for how well you can use the technique. And so taking this forward, we have Dr. Sri Ganesh talking to us about the use of femtosecond laser in a much more effective way, and that's with the procedure of SMILE. Dr. Sri Ganesh it's very difficult to introduce him because his small CV also runs in pages. So I'm just going to say that he has more than 35 awards to his credit, more than 50 publications, which is a record in itself, I think. Also, he is the chairman and managing director, Netradhama Super Speciality Eye Hospital, which was the first eye hospital in India to get the NABH quality accreditation. His main interests are cataract and refractive surgery, but I know that he has a lot of other interests, and you can actually just equate him to one of his passion, I think, which is a very latest and fast bike riding. And you can actually equate him to that. He is having also showing to be having the same power. He's always ahead, and it's awe-striking what he can do. So over to you, Dr. Sri Ganesh. He is also himself undergone press beyond procedure. So I'm going to request him to present on both the press beyond as well as the SMILE, and then we can have discussion on all the topics that we discussed so far. Dr. Sri Ganesh, the floor is yours.
Good morning, dear friends, and thank you, Dr. Rupal. It's always a pleasure to be at your webinar, and though it's a Sunday, I could not say no, and to be among friends. And I'll be speaking on SMILE and also on Press Beyond. So let me just get my slides up. Okay, so we will start with an introduction to the Relax Smile procedure. You have heard the previous speakers, and they have spoken on surface ablation, on the microkeratome LASIK and femto LASIK. But now we have the third generation of the procedure with the femtosecond laser, which is Relax Smile, which I think the pioneer of this procedure was Dr. Rupal, and we are very proud of her to have pioneered this work and also brought a lot to this procedure to refine it and make it what it is today. I am a consultant to Carl Zeiss Meditech. So do we need to look beyond LASIK? We all know that LASIK is the gold standard in refractive surgery. We have been getting excellent results and very happy patients. But then do we need to actually look beyond LASIK, and why should we look beyond LASIK and at SMILE? Basically, Relax Smile combines the state-of-the-art femtosecond technology with a very high precision lenticule extraction to provide a minimally invasive refractive correction in a single system, which is the Visumax femtosecond laser. Dr. Ramamurthy has already spoken about the Visumax laser and how it can be used for the femto LASIK. But with SMILE, the advantage is you have very clear clinical benefits. The surgery is minimally invasive, and you can do the surgery through a micro incision, 2 millimeter incision. It is an all femtosecond laser, so you don't have to shift the patient between two platforms, and it's a single step procedure. If you look at LASIK itself, it is a two-stage procedure. First, you have to create the flap either with a microkeratome or with a femtosecond laser, and this has been described in detail. And then you have to use excimer laser to ablate the cornea and then put back the flap. In contrast, if you look at SMILE, it is a single step procedure and there is no flap. A refractive lenticule is created within the cornea and it is an all femtosecond laser procedure. You don't need an excimer laser. You just make a between 2 to 4 millimeter opening through which the lenticule is extracted. There is no ablation of the cornea. The Visimax femtosecond laser is probably the only commercial laser available now. Of course, a few more lasers are coming in to do SMILE, and they've just been introduced, but again, we don't have much data on them. Whereas with the Visimax, almost 3 million procedures have been done up to date, 3 million SMILEs, and we have a lot of clinical data. The Visimax femtosecond laser has a high pulse repetition rate, which is 500 kilohertz. And because of this, you get a very low and stable energy, which is less than 300 nanojoules. And also a very small spot spacing, which is 3 to 6 microns. Because of all these characteristics, you can get a very precise lenticule. You can carve a very precise lenticule in the cornea, and you can remove the lenticule and correct the refractive error. The Visimax uses a contact glass which is curved. So you can see this is the contact glass made of quartz, and it applanates the cornea, and you have a very low suction by which it holds the cornea. So unlike many of the other femtosecond lasers which use a high suction, you hardly get any subconjunctival hemorrhage. The patient is still able to look at the fixation light. The fixation light does not disappear, so you can get a good centration on the visual axis, and it's very comfortable for the patient. If you look at the SMILE lenticule geometry, you have an optical zone which can be anywhere from 6 to 7 millimeters. And then you have a lenticule side cut, which is at 90 degrees and a minimum of 10 microns thickness, but you can increase it to up to 30 microns, especially if the lenticule is very thin and you want a better hold on the lenticule to dissect it and remove it, you can increase it up to 30 microns. Then you have the 6 to 7 mm optical zone is called the refractive cut, and this is the superficial cut which you have, the green one, and this leaves a cap thickness of anywhere between 100 to 135 microns. The company recommends a 120 micron flap, and then you have a small access incision of anywhere between 2 to 4 millimeters to extract this lenticule. This is the lenticule geometry. Let's look at the procedure itself. That is the refractive cut, and then the side cut, and followed by the cap cut, and then the access incision. So this is the procedure. You open up the access incision, and then you go superficially and find the superficial plane. That is the cap cut, and then the deeper plane. So you can know that you are at different planes, and of course, Dr. Ramurthy calls this the stop sign. You can dissect the superficial plane and then the deeper plane to free the lenticule, release the side cut, and after that you can just remove the lenticule. The procedure itself just takes a couple of minutes to do. So it's one of the fastest refractive procedures in good hands. The advantages of the Relax SMILE, it's a totally flapless procedure. So if you look at the LASIK cut, you almost have a 20 millimeter cut. So with the LASIK flap, you have a 20 millimeter cut. So this is the one. With SMILE, it is about 80% less. So you just have like a 2 millimeter cut. So it's about 80% less than the LASIK cut. So it is minimally invasive or micro incision. So that is what patients like now. They like minimally invasive surgery, and this is something that can also be marketed. And since you don't have a flap, there are no flap complications at all. Flap complications like macro and micro striae, you can see the macro striae here. And you can get flap dislocation. You also have epithelial ingrowth. So epithelial ingrowth is not a problem with SMILE unless you implant the epithelium when you're dissecting the flap. If there is loose epithelium, then you can have some epithelium in the interface. Otherwise, there is no epithelial ingrowth unlike LASIK. If you look at the post-op dry eye, there is less transection of the upper corneal nerves when compared to LASIK, because especially if you have a 120 or 130, 135 mm cap, the upper corneal nerves are spared, and you just access the lenticule through a micro incision and remove it from deeper within. When compared to LASIK, where you are transecting the upper corneal nerves, and this can cause more dry eye and delayed nerve regeneration. And this has been proven in many studies. When you do confocal microscopy and look at the subbasal nerve plexus, this was a study done by Professor Shimizu, and you can see the nerve plexus in the normal eye. SMILE 1 month post-op is almost normal, but with LASIK, you can see that the subbasal nerve plexus is kind of depleted or not regenerated. There was also a study looking at the changes in ocular surface and the inflammatory mediators, comparing SMILE with femtoLASIK. And you can see that all the inflammatory mediators, including IL-6, TNF-alpha, NGF, etc., were increased after femtosecond LASIK when compared to SMILE. So SMILE induces less inflammation because the total energy used also is just in nanojoules when compared to millijoules in microjoules in LASIK. Coming to corneal biomechanics also, there was a paper which was presented at the Innovators Lecture in 2008 by John Marshall. And you can see that with a LASIK flap, the more superficial you are, this is like an 80 micron flap, you only have 14% loss of the biomechanics strength. And as you go deeper, the loss keeps on increasing. So if you have a flapless procedure, then the biomechanical strength would probably be reduced less than with the flaps and thicker flaps especially. There was also a paper by Dan Reinstein, which looked at the corneal sensitivity biomechanical influence on spherical ablation. And with what he calculated is with LASIK, basically once you lift the flap, 120 micron flap, you lose the tensile strength. And so the RST here, suppose you have a epithelium of 50 and then the 120 micron flap, then the RST would just be about in a 500 micron cornea, and you do 100 micron ablation, it would just be 280 micron, because you have 120 flap, 50 is epithelium and 70 is the stroma. Whereas with SMILE, if you just remove the lenticule, then you're not having it's a cap, so it's not a flap, so you're still retaining the tensile strength. The RST, the total RST would be 350 microns rather than 280 microns. Because he says also that the superficial stroma has 1.5 times the strength, and because of this, you have more tensile strength. So the total effective residual corneal thickness would be almost 385 as compared to 280. This was mathematically based, and he also did the comparison of the total stromal tensile strength using a mathematical model and comparing SMILE, PRK, and LASIK, and found that you have the highest tensile strength with SMILE. Again, this is a mathematical model, so it's a theoretical model. If you look at the spherical abrasion induced, there was a paper by Dr. Chan Sui, who is again a high volume SMILE surgeon from Thailand, and he compared LASIK, optimized LASIK with SMILE, and looked at the amount of spherical abrasion induced. And as you go higher, as you correct higher myopia, he found that the SMILE had less induced spherical abrasion when compared to optimized LASIK, which translates into better quality of vision, better night vision. Why is this? Because with LASIK and excimer-based procedure, you have what is known as the cosine effect or the summer-winter effect. There is peripheral loss of energy. It's called fluence projection errors. So when the laser beam strikes, all of you all know that with the excimer laser, you have a flying spot, and this flying spot is controlled by mirrors, which keep moving and shifting the placement of the laser spots. Now, when the laser is firing perpendicular to the cornea, okay, the laser spot is perfectly round and you have full energy. But when it's hitting the mid periphery, because it is at an angle, okay, the spot is not round, but you have a kind of a coma effect, and there is some loss of energy. It is more ellipsoid, and you have some amount of loss of energy. And the extreme peripheral rays are bent, and here you have more loss of energy. Only about 50% of the energy is transmitted to the cornea, and a lot of it is reflected. So this is called fluence projection error. And then here you have lesser ablation than in the center, and this induces spherical abrasion. And so what happens is you get an abnormal corneal shape because there's less amount of tissue ablated in the periphery than desired compared to the center, and this induces a lot of spherical abrasion. So, and these induced abrasions do not bring light to a point focus, and because of this, the quality of vision and contrast is less. With SMILE, there is no fluence projection error, and the lenticule shape tapers slightly in the periphery, and it preserves the natural aspheric corneal shape. So you don't have much of induced spherical abrasion, irrespective of the power. Even for higher powers, you have less induced spherical abrasion. Now, if you look at the zone of flattening, again, SMILE has a significant wider zone of flattening post-op with femtosecond LASIK. We also did a study, and we found that the zone of flattening is 69% compared to the attempted optical zone in femtosecond LASIK, whereas with SMILE, it was almost 80%. And this was significant. There are many studies also confirming this. Again, this is because of there is no fluence projection loss in SMILE. So this translates into better quality of vision, better night vision, lesser abrasions. And there was also a study done by Dr. Chan Sui and a questionnaire regarding night vision. And he looked at the night vision scores pre and post-op for both femto-LASIK, optimized femto-LASIK, and SMILE. And you can see that SMILE scores much more in terms of night vision compared to femtosecond LASIK. And most of the patients, it either remained unchanged, the quality of night vision, or it improved. Whereas with LASIK, you had some patients who said that it is worse than before the night vision. That's because of the induced abrasions. There's also a paper by Secondo group, which looked at centration of the treatment zone, comparing SMILE versus femtosecond LASIK, and they found that decentration in SMILE from the reference point was 0.32, whereas with femtosecond LASIK, it was 0.516. There were a few, because they looked at the pentacam and the thinnest point in the pentacam, there were a few fallacies in this study, but nevertheless, with the smile, you are always centered on the visual axis because the patient is fixating at the fixation light and the lenticule is centered around the fixation. Whereas with LASIK, most of the LASIK machines, it is along the pupillary axis. So especially if you have a large angle kappa, then you can have more decentration. Some of the newer machines like the Contura center on the visual axis, and so the results may be slightly better than the other excimer lasers. But if you are even with the other excimer lasers, if you're compensating for angle kappa, then your results will be better. And this was demonstrated by a paper by from Middle East by Maria Clara. And we did a study once we got we were doing a lot of femtosecond LASIK with the intralace, and once we got our Smile machine in 2012, we started Smile, and then we did a comparative study. We wanted to know whether Smile is better than femtosecond LASIK, so we did a comparative Smile comparison between femtosecond LASIK and Smile. We looked at the visual and refractive outcomes, and this was published in the Journal of Refractive Surgery 2014. And we found that with the Smile group, actually both the refractive results and visual results were better, and higher order aberrations were significantly higher in LASIK group than with the Smile group. And we also looked at dry eye, tear osmolarity, and post-op dry eye and glare were also significantly higher in the LASIK group. If you looked at this is again a study by Rupal Shah, which he has published. And if you look at the 1 year outcomes, predictability of Smile, you can see that the predictability within plus or minus 0.5 is 98%. So it is very high. And the stability also, if you look at the stability from 1 month to 1 year, with Smile, there is hardly any change in the refraction. It is very stable. So this is probably because of better biomechanics, and there is lesser regression. There's also 5-year results. Now, of course, the latest is a 10-year result, which has been published by the same group, Walter Secondo's group, and they found that the stability with Smile was excellent. Mean regression was 0.07 diopter. And 10-year result, I think, is just less than 0.3 diopters. So to conclude, Relax Smile gives excellent visual results and good refractive stability. At our center, almost 85% of refractive procedures are Smile now, and patient satisfaction is very good. There are no flap complications, less induced aberrations, no significant dry eye. For me, after femtosecond LASIK, you just need to ask the patient to wait and recheck the flaps to see if there's any stray or any dislocation. With Smile, you can send the patient from the table. So I'm a little bit of a lazy surgeon. So with Smile, I take half the time compared to a femtosecond LASIK, and then I don't have to again go back and see the patient. So you can, once you do it, you can forget it. And these patients are very stable, very happy. They keep sending in more patients. It's a very patient-friendly procedure. It's painless, faster healing, less post-op restriction. So for a patient, if you give them more restrictions, they feel that the procedure is more complicated. If it's painless, if it takes less time, and there are no restrictions post-op, then it's like magic for them. I just went in, 5 minutes, I was done, and I didn't have to take any precautions. Next day, I was back to all my work, and then I was doing all my even sports, going to the gym, everything. So they feel that it is minimally invasive. So that's about Smile. Thank you very much for your attention. If there are any, otherwise, if there are any questions on Smile, I can take it. Otherwise, we can go on to the next talk of Pascal.
Why don't you finish your talk and then we can have some questions.
Okay.
Excellent overview, Dr. Ganesh.
Yeah, it was just an introduction to the SMILE procedure.
Yes, I'm sure there would be some questions, but I think after the press beyond talk, we'll direct the questions to you first and then we'll follow the other discussions.
Let me just share my screen. Is my screen visible now?
Yes.
Yeah. So we'll talk about presbyopia now, and this is another technology available from Carl Zeiss Meditech. So I'll be talking on patient selection and presbyon. So I am a consultant to Carl Zeiss Meditech. So presbyopia is the holy grail of refractive surgery because almost everybody becomes presbyopic at some point or other in their life. And if you can treat presbyopia successfully, then you have a huge market to cater to. But it also has its challenges because you're dealing with a patient with clear lens, and patients' expectations are high. They want to become younger. And presbyopia can also be a progressive condition where the refractive error or the reading power keeps increasing. So if you look at the clinical decision pathway, there are many procedures available for correcting presbyopia. So there's always a confusion as to which procedure you should adapt and which will give you the best results for you or your patients. So you have corneal inlays. The most popular was camera, but by and large it is becoming obsolete. Here the inlay has a 1.6 millimeter aperture and works on the pinhole principle. Then the other inlays like the FlexiView and the Raindrop have by and large become obsolete. If you look at LASIK procedures, you have monovision LASIK, which has been being done for decades now, and especially places like US, but it has its own share of problems, and only about 65% of patients can accept monovision LASIK. Monovision SMILE also can be done. Then you have multifocal LASIK like Presbymax or Supracore. Again, not very popular, though some of them are doing it. And then you have laser blended vision or Presbyon, which works on the principle of increased depth of field by induced abrasion and micromonovision. And this procedure is becoming more popular and works very well. Of course, the other options are refractive lens exchange with a multifocal IOL or a trifocal IOL. And now, most recently, you have presbyopic phakic IOLs. So my protocol, again, if the age is 40 to 65 years and patient has a clear lens, I prefer to do presbyon if they are eligible for the procedure. Age above 65 years, if there's cataract or if they have narrow angles, then I prefer to do cataract surgery with trifocal or a need of lens. So sometimes they may be between 40 to 60 years, but and having a clear lens, but they may have other conditions like a very shallow anterior chamber and narrow angles. In that case, I would prefer to do a refractive lensectomy. I always do an eye trace and look at the dysfunctional lens index, DLI. I also do a HT analyzer and look at the scatter, again, to rule out early cataract. If the DLI is less than 5, then you prefer to do a cataract surgery with a multifocal or a trifocal lens rather than presbyon, because this can be progressive, and even if you do presbyon later, you'll have to do a cataract surgery. Just a minute. So if you look at the patient selection for Presbyon, the patient should be suitable for LASIK. The corrected distance vision should not be worse than 20/25 in either eye. Age 44 and above. They should be presbyopic and dependent on the reading glasses. They should be a motivated patient who wants to get rid of the reading glasses. And they should pass the 1.5 diopters tolerance test. They should have quick suppression and fusion. And they should be able to tolerate at least 0.75 diopters of anisometropia. Range of correction for Presbyon, for myopes, spherical refraction up to minus, spherical equivalent up to minus 8.5 diopters. And for hyperopia, up to plus 5.75 diopters. And you can also treat emmetropes. Avoid patients with very high expectations, because many of these patients actually think that they can get back accommodation, they can become like a 20-year-old and be able to focus for all distances. So you'll have to tell them that it's a lifestyle procedure and it's going to help them reduce their dependence on glasses, and it's not a perfect solution. You can't make them younger, but it's just that they can manage without the glasses. And very low myopes, when you start off with, it's better to avoid less than 2 diopters, because these are patients who just remove their distance glasses and read, and their reading is excellent. And these patients can tend to be dissatisfied. So until you are experienced and you know how to counsel and then you fine tune your results, it's better to avoid the very low myopes. Preoperatively, you'll have to counsel patients to avoid comparing both the eyes post-op, because some of them keep doing this. And these are patients who would notice the difference and keep coming back to you with complaints. So you should tell them that this procedure would correct one eye for distance, the other eye for intermediate and near, and there will always be a difference, so they should not compare. And you should also tell them that they will adapt over a period of time. The neuroadaptation takes at least 3 months. There are chances of enhancement in the future because presbyopia can be a progressive condition. And if there is some early cortical cataract, peripheral opacities, you should also tell them that they may need cataract surgery in the future, but they need not go in for multifocal IOLs, because whatever treatment you have done will still be effective even with a monofocal IOL. If you aim for an isometropy of 1.5 to 1.75, they can still maintain this correction. There are different steps in evaluating a patient for Presbyon. The first step is verification of refraction. This has to be done very thoroughly, and you should get the proper refraction and refractive error. You should also look at the accommodation amplitude to verify the functional age. You should check for eye dominance and check for the 1.5 diopters tolerance test. You'll also have to check for suppression and fusion, and then you finally plan the software with the CRS master. So ocular dominance test can be performed with a patient wearing distance correction. You can do the following test, the shooting test, where you ask the patient to point as if he's shooting, and he'll automatically close the non-dominant eye. Hole in the card test, where he uses a hole in the card and brings it from distance to near. Automatically, he brings the hole in front of the dominant eye. You can also ask him which eye he uses while shooting with a camera, or also the pointing test, where he points at an object and then closes the eye alternatively to see whether the image is shifted. Micromonovision assessment is very important. So the standard micromonovision protocol corrects the dominant eye to plano and non-dominant eye to 1.5 diopters, irrespective of age. So patients are tested for tolerance with the intended refraction in place, and the amount of cross blur reported by the patient during simulation is evaluated. Cross blur is a lack or reduction of intraocular blur suppression. They are not able to suppress the blur, so they feel uncomfortable. They may see shadows or doubling. So this is the micromonovision assessment. Here, patient is, you put in the distance glasses, and ask the patient to look at the distance. Then you put a 1.5 diopter plus 1.5 in front of the non-dominant eye. Here the left eye is the non-dominant eye, so we put a 1.5 diopter lens. This patient is hyperopic. Ask them to read the board and see if they are able to read the last line clearly. This patient is reading clearly with the 1.5 diopter in front of the non-dominant eye. Then you make them read the near chart, and then he's able to read N6 comfortably. You ask him if it is clear or whether he has any doubling or blur. In this case, he says it's comfortable. He can see clearly. And then you again ask him to look at the distance board. And then you close his dominant eye. You're closing his right eye. Ask him to look. And then he says it is blur. He is not able to see properly. So he's struggling to read. So once you remove it, then he says it is clear. You ask him if it becomes totally clear and show him the difference. So this, you're checking for blur suppression. And you show him that it's blur, now it is clear. Now he is happy. So he's able to, he has a good blur suppression and he's able to see the distance clearly. So this is 1.5 tolerance test. So suppose you have a patient who is non-tolerant to the 1.5 diopters. They say it is blur or doubling. Then you can decrease that to 1.25 in the non-dominant eye. If it tolerates well, then the target is 1.25 diopters. Still with 1.25 also they report cross blurring. You can progressively keep reducing the add by 0.25 diopters until the patient reports minimal cross blur and is happy with vision at both distance and near. So there are some concerns about near vision and the patient is not able to read clearly with the 1.5 diopters. Then you can increase the anisometropia to 1.75 to 2 diopters in the non-dominant eye. Set the dominant eye. You can also set the dominant eye to minus 0.25 or even minus 0.5 diopters so that the amount of anisometropia is reduced between the eyes. Emmetropic patients, you'll have to treat both eyes because the distance eye also can benefit by the increased depth of field and their intermediate vision will be better. And most patients are not exactly plano even in the dominant eye. They may have a small cylinder 0.25 or 0.5 cylinder. So this is the treatment planning with the CRS master. So you have to enter the manifest refraction, both the eyes, and then the age and the functional age, then the dominant eye and the 1.5 diopter tolerance test. And then you have the target refraction in the non-dominant eye. The default target 1.5, but what we are applying here is the patient is hyperopic. In hyperopic patients, we slide because there can be a little bit of regression because of healing with the epithelium. We like to keep the target a little higher, 1.75 or 2 diopters. This we have learned from experience. And it shows the optical zone intended correction in both the eyes. And then you can transfer this data. You'll have to put in the Z value also, the Z4 value, which is the spherical aberration. And this you can get from the abrometer. If you don't have the abrometer, then you can leave it default. So this is the Z4 value for both the eyes, 0.46 and 0.85. And then you can proceed with the treatment, which is just another LASIK procedure. Coming to my own case, I would like to describe my symptoms. I was emmetropic throughout my life, and then middle age, I got a little bit of hyperopia. I had difficulty in reading small prints in dim light by 45 years, and then my intermediate vision also was affected by 47, and I became totally dependent on glasses. I was wearing progressive glasses. I tried multifocal contact lens, but it was not an option because I had a lot of discomfort. I was not able to tolerate the multifocality, and I had a lot of night vision issues. Then I decided to get refractive surgery done. And the factors which influenced me was that I was totally handicapped for near and intermediate without glasses. And it was more for functional reasons than cosmetic. And I think one of the biggest motives were that my refractive patients kept asking me about my glasses. And it's difficult to explain to them that this is presbyopia, it is different from myopia and all that. They used to say, Doc, if when you are wearing glasses and you're advising me to get rid of glasses, so it is an embarrassing situation. And difficulty while doing surgery also, when you have to see both the monitor and the microscope, then you have to wear your glasses. And even while operating cataracts, if you want to look at a chart, if you want to look at the toric chart, then it's totally blurry, you have to wear your glasses. And I also do a lot of sporting activity like scuba or bike riding, and then it's difficult with the glasses. I have a whole collection of very nice shades, and I was not able to wear them. I had my fears and questions. Will it reduce my quality of vision? Because I'm a high volume surgeon, does teleopsis get affected? Will it interfere with my surgical work? What will happen if I don't get an optimal result? Can it be enhanced? What type of procedure should I get it done? And who will do my surgery? These are all questions. I didn't want to go in for an intraocular surgery with trifocal lens because there can be serious risks like endophthalmitis, recurrent uveitis, CME, retinal detachment, even though it may be 0.2 or 0.3%, but still there is a risk. And moderate risks also can be there like PC rupture, PCO, and you can have other issues like glare and halos, loss of contrast, refractive inaccuracies. So these are all issues, and I had clear lenses, so I didn't want to opt for that. Looking at the multifocal LASIK, I had some experience with the Presbymax. We have a few Schwind lasers, and I did Presbymax also, and I looked at my own data, and patient satisfaction was not that good. And 38 eyes had, almost 45% of the eyes had one or more lines loss of vision for distance at 15 days. And even after 6 weeks of follow-up, some eyes had a 2-line drop in distance vision. So, multifocality, even with the contact lenses, I was not very happy with it. Then I finally selected Presbeyond because I found that with Presbeyond, you had the highest patient satisfaction. You had good functional vision. It had the safety and track record of femto LASIK. And I had the follow-up data and satisfaction of my staff who underwent Presbeyond for about a year and a half. I treated a few of my staff and they were very happy. It's easily adjustable. You can enhance it. It is reversible. There are no permanent visual effects like glare and halos. Initially, you may have some amount of glare, but it can be corrected with glasses. It closely simulates natural condition existing in many of us. Those who have a little bit of myopia in one eye need not wear glasses at all. Typical example is Dr. Ramurthy and even Dr. Mahipal. They have not worn glasses for years because they had a little bit of myopia in one eye. And it gives very good contrast sensitivity and stereopsis. And it will not affect my surgery. All I have to do is just adjust the microscope ocular for the non-dominant eye. And I can get a very nice depth and stereopsis. And I can even maintain blended vision even after cataract surgery later on in life, and it will not interfere with the surgery itself. This was my pre-op data. I was about 0.75 diopter hyperopic, but pushed it almost up till 1 diopter. I was accepting, improving to 6.3 with a small cylinder, and this was my topo, which was normal. This is the Atlas topography again. And this is the CRS master. I had slightly higher spherical abrasion. You can see right eye 0.63 and left eye was 0.61. So slightly higher pre-op spherical abrasion. And then the procedure itself, I got it done during live surgery, and Professor Dan Reinstein did this. Dr. Rupal also was there in the OT. So about 500 of my colleagues were watching the procedure. So it's like a LASIK. You just lift the flap and then do the procedure. So I was able to read even the smallest print after the procedure. Immediately after the procedure, you can watch the whole video also on YouTube. You just have to put Sri Ganesh plus beyond. And this was my post-op data, 3 months. Right eye plus 0.25 diopters, but uncorrected best corrected was 6.3. Left eye minus 1.75 diopters, 64.5. Binocular vision, uncorrected 6.3 and 5. Intermediate vision also was excellent. It was N5 at 60 centimeters, N8 at 80 centimeters binocularly. N5 at 60 centimeters, N6 at 80 centimeters. Stereopsis 60 second arc, corrected 20 second arc, and excellent range of vision. This was my post-op topography. You can see steepening, central steepening more in the left eye because it's a hyperopic correction. This was some of the pictures pre-op where you can see Dan Reinstein is making fun of me because we had put this board there and I was wearing glasses. The next day I was doing live surgery. I did a complex cataract surgery. It was during a FACO festival. Do I have any side effects? Yeah, for the first 6 months or so, I had some mild dry eye, especially after a long surgical list, but now I'm perfectly fine. It's 4 years since I got it done and my refraction is very stable. I don't need glasses. I'm able to see perfectly. The vision is very stable. I had halo at night in the left eye for the first 3 months. It was correctable wearing glasses. And I used to wear glasses only for high-speed highway driving. 1 week after the procedure, I had gone to Germany. I was driving on the Autobahn in rain, and then I needed the glasses to see clearly. But now there's absolutely no night vision problems, and I'm very happy, very satisfied, and strongly recommend this procedure to my colleagues, also my patients. It has indirect benefits also. So before, you can see the plus beyond surgeries were at one particular level, and after my surgery, I got it done. Even in the paper, we had an article. Doctor gets taste of his own medicine, says goodbye to glasses. And then after that, the procedures actually tripled, and minimum chair time, because patients, once you tell them that you yourself have undergone it, then they don't have any more questions. They're convinced about the safety. And you can see my practice patterns for presbyopia and plus beyond. Over the years have been increasing. You can see this is plus beyond, and over the years it has increased, and the other procedures actually have remained the same or come down. Just a brief on our experiences. 240 patients operated for plus beyond from January 2014 to August 2016, and the mean age was 53 years. And this was the distribution of the refractive errors. Most of them were equal distributions of hyperopic and myopic patients, and few ametropic patients also. This was the binocular distance visual acuity, and you can see that in almost all the patients, we had, I would say 90 to 93% of patients, we had 6/6 or better vision for distance. And this is at binocular uncorrected binocular distance visual acuity at 12 months. 92% had 6/6 or better at 12 months. And this is a binocular uncorrected near visual acuity at 12 months. And you can see that 96% had N6 or better at 12 months. This is the spherical equivalent change. Of course, left eye, the non-dominant eye is on an average minus 1.36. Right eye minus 0.16. We also use the Salzburg reading desk. It's a tool for systematic evaluation of reading acuity and speeds. And we found that 100% of eyes had reading speeds of better than or equal to 80 words per minute, which is the normal. So the reading speeds, the functional vision is excellent at 70, 80, and 90 centimeters. And we also did the defocus curve, and you get a depth of field of approximately 1.5 diopters, which is what we aim for, and which is excellent. We also looked at the higher order aberrations, both in the myopic eyes and the hyperopic eyes, and you can see there was a slight increase, more so in the hyperopic eyes and emmetropic eyes when compared to the myopic eyes. So with Presbeyond, you're basically increasing the higher order aberrations or bringing it under control in a particular range so that you get the maximum increase in the depth of field. We also looked at contrast sensitivity pre-op and post-op. There was not much of a difference, a very minor drop. So the contrast is excellent. We also had a subjective questionnaire at 12 months. 95% were happy with distance vision, 97 happy with near vision, 100% happy with intermediate vision. Glare and halos at night at 1 year were nil, no other symptoms like headache, nausea, diplopia. We enhanced 6 eyes out of the 240, 6 patients out of the 240, which is 2.5% enhancement rate. Some patients needed glasses for reading fine print, 8, which is about 3.33%. They didn't want an enhancement, they just took reading glasses. So to conclude, you get very favorable distance, intermediate, and near visual outcomes, good functional quality of vision without loss of contrast, and it can add value to your refractive surgery practice and increase your patient load and the type of patients you cater to. So it is a good option to get into the presbyopia practice. And I think Presbeyond is an excellent option to start. Thank you very much for your attention.
Thank you, Dr. Shri Ganesh. This was really complete. And even some questions that came to my mind, you answered before I even put them. I just wanted to ask you whether you promise your patients independence from glasses when you are offering them Presbeyond, or just a reduced dependency from glasses?
For all patients, I don't promise them the moon. That is one thing that you should not do. You should not promise the moon. So presbyopic patients also, I don't tell them that you can be free of glasses. I tell them that it reduces your dependence on glasses. It improves your quality of life, because you don't, if you want to read a menu, you want to read a price tag, then you can read it. But if you want to read shares in Indian Express, you may not be able to read it, the share value, because it's very small print. And it would reduce your dependence, but it would not completely make you get rid of glasses. And over a period of time, if your presbyopia increases, then you may have to wear glasses, or you may have to undergo an enhancement.
Also, if somebody is just about to turn presbyopic, say they are in the range of 39, 38 years, and if they come to you for refractive error correction, do you tend to add this profile, the non-linear aspheric profile, or do you wait till they become presbyopic and then add it?
I would not, if they are able to read N6, then I don't do a Presbeyond for them. I don't use the Presbeyond profile also, because these are patients, if they have a refractive error, we correct it. If they are emmetropic, then I don't really advise Presbeyond for the very early presbyopes, because the early presbyopes can be dissatisfied. They have to be totally dependent on their glasses, and these are patients who have a pair of glasses in their car, in their office, at home, and they're totally dependent on glasses. These are the patients who will be satisfied. So
no,
these are the patients
you may not do the micro monovision part, but would you just add the aspheric profile?
You can see, even with the regular, because I do smile, mostly I do smile. So then I do Presbeyond for the presbyopic patients. And if they are pre-presbyopic or younger patients, I do smile. So for smile, anyway, you have good control of spherical aberration. So if you're doing LASIK, if you're doing LASIK, then you can use the Presbeyond software, and you can add less. You can add 0.75 also, or you can just do the Presbeyond profile without a micro monovision, which will just give them increased depth of field.
Do you think if somebody has undergone a Presbeyond When they get cataracts, it's okay to just put a monofocal IOL rather than a multifocal one because the Presbyon profile still works.
Yeah, I've had 3 patients whom I've operated post Presbyon for cataract surgery. I use a neutral aspheric or a positive aspheric IOL like the sensor, or even Zeiss has a neutral spherical aberration lens. So you can just use that, and you aim for 0.75 diopters in the non-dominant eye.
This question is for all the panelists. There has been some comparison of the SMILE procedure with the Contura. I would want you to throw some light on what is Contura treatment and how is it different from SMILE, and whether it's a fair comparison to me. Dr. Ramamurthy?
Yeah. I think, we have been doing both these, and recently we are actually doing a contralateral eye study where we are doing Contura in one eye and SMILE in the other eye. And I believe both of them offer excellent results. And as far as patient satisfaction, when the normal myopic patients are concerned, it's very much comparable. Of course, the quality of vision, especially when it's objectively measured as far as the correction is concerned, is somewhat better in Contura. But refractive accuracy wise, both of them seem to perform equally well. And when there is a significant cylinder that is there, I would definitely tend to shift towards Contura. But otherwise, I think the results are quite comparable. We have actually just completed a series of 100 patients and waiting for a 1-year results. But the initial results is just that, the certain type of aberrations, especially the vertical coma, seems to be slightly higher in a SMILE, and spherical aberration is slightly more in the Contura group. But overall, the results are quite comparable. It's only at the end of 1 year that we'll really know how exactly they're done.
Dr. Sri?
Basically, what is Contura? It's not a magical word. It's just LASIK. It is LASIK. It may be microkeratome LASIK. It may be femtocare second LASIK. End of the day, it is again LASIK with probably a different software for planning, where you're looking at the topography. It is taking in the topography and data from the topography to design the treatment. But again, you have a flap. You need an excimer laser to ablate. All the problems related to flap are there. All the problems related to an excimer laser and ablation with the cosine effect. That's why Dr. Ramamurthy has found that the spherical aberration is more. So you cannot compare it with SMILE, which is a totally different procedure. It's like comparing apples with oranges. So you should compare Contura with another excimer laser platform and see the performance. You cannot compare Contura with SMILE, because it's just again femtosecond LASIK, and there are so many papers which show that SMILE is superior to femto LASIK. Now, the only plus point of Contura, I would say, is where you're treating on the visual axis when compared to the other TopoLink lasers which are there, whether you take Schwind or whether you take the MEL. But if you're doing a compensation for the angle kappa, then again you are centered on the visual axis. The other thing is, treating the topography is something which I do not believe in a normal cornea, because refractive surgery is about correcting the refraction. Whether you take phakic IOLs, whether you take LASIK, whether you take PRK, whatever procedure you are doing, you are correcting the refraction. Finally, if you have corrected the refraction, then the patient is happy. If you have an abnormal cornea, then you need to treat the abnormal cornea, and then you do a TopoLink LASIK. So the whole concept, I feel, is a little warped, because you have astigmatism on the cornea, which is countered by the lens. You have lenticular astigmatism. Now, if you correct that, if you correct the corneal astigmatism, then the lenticular astigmatism will show up. So you're not correcting the refraction completely. Again, they will have to make some kind of adjustment for that. If there is a lenticular astigmatism, then you cannot really treat the corneal astigmatism with TopoLink. But I basically feel that it's more of a marketing that is done. I mean, if you look at the other excimer lasers, and if you compare a wavefront optimized to Contura, I'm sure there would not be a big difference. I don't know if Dr. Ramamurthy has compared your wavefront optimized treatments with the Contura treatments. with femto LASIK, and then you would find that the results are probably better with the optimized treatments. I mean, that is my view, but as far as comparing it to SMILE, I think it is not a very fair comparison because they're totally different procedures. It is lenticle extraction and that's an ablative procedure. So you can't really compare them. And SMILE has a lot of advantages because it's a flapless procedure. It is minimally invasive. The biomechanics are different. Dry eye is different. Contour, the dry eye biomechanics is the same as any other femtosecond laser. Femtosecond LASIK.
I think, many of the points you mentioned are quite valid, Sri Ganesh. And let me right at the outset say that the Contour is not just correction of the aberrations, but it's basically a wavefront optimized platform on the visual axis. It's built on the visual wavefront optimized. So it reduces the amount of spherical aberration that's induced, as well as it takes care of the pre-existent aberrations. And most of the videos that I showed as far as complications are concerned, even in my femtosecond platform, talk was on my intralace. So this was for the simple reason with my VisuMax, I'm not getting any problems with my even creating a femtosecond flap, not only because of the machine that I'm using, but also because of the experience that you have gained over time. So I think that applies to all of us. So it's not as if, you ditch one procedure and say the other is much better or something. I think in the right hands with the right kind of understanding, all these procedures have their positives and negatives. I, for one, am thankful that I have the freedom of choice to pick and choose what's best for each and every one of these patients and offer them. So if there is a patient coming to me with a significant amount of, say, -1, 1.5, 2 diopters of astigmatism, then I would definitely tend to go towards a femtosecond laser-based procedure like a Contour, because though I know that manual compensation, etc., is there, but I'm not very convinced about it, and there are not enough material available also to rely on that. While the astigmatism correction with femtosecond femto LASIK is reasonably well established. And again, as far as dry eyes, biomechanics, as for what you told us about the mathematical model, it just assumes of Dan Reinstein. I have the greatest respect for him. He's one of the forerunners, but then it just assumes that the cap continues to offer a mechanical stability to the cornea. I think that once the connection between the bed and the cap is no longer there, it's questionable whether it contributes to offer a strength to the cornea. And I do not think that biomechanical measurement studies have really shown that it is superior. And again, the comfort level of the patient is definitely better with SMILE compared to a femtolasic procedure. But when you compare it 3 months, 6 months down the line, whether it's tear stability or the cornea regeneration of nerves, the results have both become comparable. I think we can go on talking endlessly about it. It's just that we have to be thankful that we have these choices, and each one of us can pick and choose what's best for us, what works well in our hands, and what's good for our patients.
Yeah,
That's
finally,
really well said.
it is.
We also have to look at the pockets.
Yeah, it's your experience with the procedure.
Not everybody can
how
afford
comfortable.
the latest procedure, so it's good that we have everything in our armamentarium.
We have priced femto Contour similar to SMILE, and actually by doing a femto Contour, what we gain as a hospital is more than what we gain by doing a SMILE, simply because the SMILE PA costs significantly more.
No, so I was talking about the patient's point of view.
Absolutely, that's the reason
gains more.
That we very much do microkeratome LASIK also, because we don't want to refuse patients surgery just because they can't afford femtolasic based procedures.
Dr. Chitra, there are questions for you. Are there any way to avoid haze? And if it happens, for how long would it stay? And how many percentage in your case do develop haze?
Actually, we are very particular about not treating more than -5, or very rarely we would have treated -6. And we use mitomycin even if you're doing a power correction of -1, 0.02% for 30 seconds, irrespective of the refractive error being corrected. And we keep them on vitamin C twice a day for 6 weeks, and we keep them on taper topical steroids. and coolers when they go out for ultraviolet ray protection. I believe that in our series, actually, we've not had haze at all. It was just some referred patient with haze where we had to treat it. Maybe a minimal nebular haze was seen one odd patient who had actually stopped steroid drops, not even used it for a week or so. But there are surgeons in the different other institute and capable people who we have even treated up to -8 and 9 and claim do not have haze, because in their setups they have used mitomycin for every diopter, 10 seconds of exposure to mitomycin. So, each to their hands. We need to be conscious that we have enough residual bed. But today, the facilities which we have, I don't think haze is a big issue. If you are going to be, you should be studying your own results and following it up.
How do you manage?
Of course, the laser ablation platform and larger optic zones, all these things are important.
How do you manage it once it occurs?
If it is very minimal, steroid drops would do, but otherwise you can mechanically or with PTK, you can scrape the epithelium and then you could place mitomycin and deal with it. I have just done one patient actually. I've never had a situation of haze.
So I think it's a better short profiles, because most of the lasers now have a short profile where one shot falls at one place, and by the time the next one comes around that same place, there is time for the first heat generation to cool down. And therefore, I think the haze also becomes less because there is no heat generation. Plus, I think use of balance of solution and a chilled BSS as well as better profiles are making the PRK procedure definitely get a comeback. I also wanted to ask all of you, are there any special care in the COVID era that you are taking when you are doing your refractive procedures on the cornea? So we can start with Dr. Partho.
Yeah, well, as we just discussed, the use of povidone iodine, which we never used in the cul-de-sac, is one aspect that we have changed. And but to use it and then let a certain amount of time elapse, at least 10 minutes in the while the preparation is going on, and then take the patient up and make sure that a very good purification is done, so that every bit of the povidone iodine is washed off. Apart from this, the usual care for the patients going into an OR, having the mask, and the personnel having the shields as well as double protective masks is what we do for our patients.
Anything else that anyone would like to add?
I think you said it all. Go ahead, Sri.
Yeah, I like to, when they wear the mask, I like to tape the mask so that there is no, when they are breathing, the air that they breathe out does not come up to their eyes. So that is something, of course, we drape, but before draping also we put a tape. And this we are doing routinely even in the outpatient, because I find that when you do the 90D or you're examining them on the slit lamp, the lenses fog up. So it's very difficult to do a examination. So always before they come into my chamber, we put the tape onto the mask, and so it's both in the OPD and in surgery.
કાલે કચરો ફેંકી દઈશું, પણ કોથળો રહેવા દઈશું, કોથળો પાછો લઈ જઈશું.
I know a little bit of Gujarati as well.
I also wanted to ask, do you get a COVID testing done for every patient that you are going to be operating on?
No, we don't get a COVID test done for all of them, but we screen them. We check the temperature, pulse oximeter, take the history, family history, and whether they have had any symptoms, and then we do it. And we wear PPE and take all the precautions. Because refractive surgery patients, especially if you ask them to get a COVID test done, they may just put off the surgery. And that's what happens, saying that, okay, and they never come back. And I don't think it's really, COVID test also is not 100% guarantee. Many of them, they're false positives, false negatives, so you never know. So it is better to look at every patient that they are suspicious, wear the PPE, handle properly, clean the bed and everything with Lysol after the procedure. The other thing I wanted to say is we were cleaning with sodium hypochlorite. But please don't clean your OT or instruments with sodium hypochlorite because you will have rusting.
Yes.
And what happened is even the zoom and all that gets stuck, and the internal parts can rust. And we had to change some parts in the microscope, and even you can see that the rusting is more even on all your trolleys and all that if you use sodium hypochlorite. So just use Lysol. So we clean with Lysol after every patient and then do that. Some of the centers are doing tests routinely, but we are not advocating it as such.
Yes, because it would also not mean that this person, you have to wait for the result of the test. That would mean that you would spend some time, some 2 or 3 days at least, before you get the results. In that time also, patient is moving around. He can still be a carrier when he enters your clinic. So
I think
it doesn't make sense.
It's almost 7 months since COVID came along, and now we're learning to live with it. And I feel that as ophthalmologists, especially cataract and refractive surgeons, our risk of COVID, either transmitting or getting it, is just the same maybe a little less in the operation theater compared to seeing patients in the OPD. Because, our distance from the patient is quite significant. And as both of them mentioned, we also, we wear double mask and a surgical plate plus a N95 mask. And as far as the patient is concerned, they're all given a mask and tape. And between cataract theater OT, between each patient, we completely clean up the theater, wipe it off. But in LASIK theater, because you do not want the smell of the chemicals there, it's just a wet mopping that is done. And obviously, sometimes in microkeratome LASIK, we used to reuse the microkeratome immediately. That's not done when we are treating 2 patients subsequently. But the microkeratome laser numbers as such are quite small. And with thankfully with femtosecond LASIK as well as SMILE and PRK, there is very little usage of repeat instruments. So other than that, I think very important point that Partha made, which all of us are adhering to, is trusting COVID-19 to do the job for us. And we used to, because of the presumed chances of DLK with COVID-19 in LASIK, we are not using it. But now routinely, I think most of us have started using it, not only on the lids, but also in the conjunctival cul-de-sac, in the hope that it will do away with whatever virus is there, if at all is there.
And
that's another advantage with the SMILE procedure. The SMILE procedure is not affected by smells.
Yes.
So you can clean your OT even with Lysol. You can wear your aftershave also while going into the OT, unlike with PRK and LASIK.
I use the same machine for femtosecond laser also.
So
and
you
the same
still keep the restrictions. Apart from COVID, are there any other blood tests that you do for your patients routinely pre-operatively?
Refractive?
For corneal refractive surgery, do you need to have
we do
something like an HIV testing?
HIV, HBsAg we do for all our patients.
You do?
Yes.
All of you do for all your patients?
We don't, because as per NACO guidelines, you have to counsel, you have to take special consent forms, which many patients will be hesitating. If you are doing it without telling them, then it is against the NACO guidelines. You can be penalized for that. So to do HIV testing, you have to go as per the NACO guidelines. You have to submit reports. You need to take consent forms. You have to have a counselor. So again, this is quite a bit of a problem. If you are reusing blades for LASIK, then definitely you have to do it. But otherwise, I don't think it is required because you are taking all the precautions.
So we do tell our patients that we are doing HIV and HBH testing. Maybe patients down south are, we've not had patients creating trouble about that.
No, but as per NACO guidelines, you need to have consent form also.
But do you find people to be, what percentage come positive?
Very low percentage. It's more often, surprisingly, more chance of HBsAg being positive than HIV. And, but it's just that we take enough precautions, make them as the last patient, and make sure that the extra gowns are worn not only by the surgeon, but by the other staff also. And yes, there are some patients who object to it. Then we tell them that, it's as a matter of routine, we do it. It's for our own benefit also, just in case we are operating another patient who is HIV positive, and we take him in immediately, you after him. it might be bad for you. So as a rule, we do it, and we find that with.
But is there a real chance of transmission if you are changing all the sets that you are using and if you are not reusing your blades? Or if you're doing something like a femtoLASIK where you're not really, coming across any body fluids from one person to another,
Actually,
do you think there is a real chance of a transmission?
Yes, definitely. If it's a patient, is an HIV patient, there is every chance of we change the drape, we would change the trolley, we would be protected, and it cannot be taken so casually. Maybe
but anyway, you change for all patients.
Yeah, you
if you're
change
using
for all
disposables,
patients, right?
you change for all patients. It's not only if they're HIV or
yeah, you change it anyway.
HIV transmission is less than HBsAg. HBsAg, the virus survives. HIV, the virus is very fragile. So we are more concerned about transmission of HBsAg. But anyways, for every patient, if you are going to change all the instruments and everything, then that should not be a problem.
Dr. Partha, any idea whether it's medico-legally implicated?
See, again, state, health is a state subject. And like for COVID also, the state regulations are different from different parts, different states. But medico-legally, it has not been instituted that this has to be done before routine surgery, and both HBsAg as well as the HIV. And most centers don't do it. Our center doesn't do it. And we take all the precautions so that the transmission is avoided.
I think for want of time, we need to move on. We need to thank Dr. Sri Ganesh because he's going to leave. He has some personal commitments which he must follow. And so thank you very much.
Thank you. Thank you, Rupal. It was a pleasure being in the webinar and meeting all of you all. Thank you.
Thank you
so much.
Thank you.
And we quickly move on to the next session. And I would invite Dr. Chitra to talk about those patients who have already have started showing some lenticular changes and still wants freedom from glasses. And what alternatives do we have? If there are any other questions, please put it on the chat and I will try and get the answers from them later or when we have another discussion session. Dr. Chitra, please.
Can you see?
Yes.
Yeah. So back to cataracts after a whole lot of time spent on refractive surgery and so much of information gained. My talk, I hope, is not boring because I'm going to be talking more on the optical principle, but I'll try to make it as relevant as possible. So essentially, what change has come as far as multifocal IOLs in the cataract era is today, that patients are quite receptive to the fact that they want uncorrected vision for all ranges of distance, but they are quite clear that they want their quality of vision to be retained and they would definitely want a lifelong guarantee. So there were some barriers of adoption. Rather, what was seen was, like in 2009, it was seen that only 6.8% of the patients had actually undergone presbyopia correcting IOLs. But after getting the best of biometry and formulae and the best of IOL designs, in 2017, again, the adoption was only 7.4%. So there was some kind of a lacuna there. Although the best of IOL designs have come in, what was the change? So essentially, as far as the patient is concerned, largely they have come to understand that there is a possibility to access the advanced technology in capable hands and the facilities are there. So probably there is some amount of surgical confidence in offering multifocal becomes necessary. Of course, the surgeon has to view the clinical performance of the previous generation multifocal IOLs, has to spend that extra time with the patient. And of course, we are all cognizant that insurance is not covering. So then the challenge is the patient demands are on the increase today, and surgeons are a little unsure whether they could deliver the best as they could with the other IOL platforms. So probably the 5 factors which have to be looked into is the profile of the patient, the age and his lifestyle, and also whether does he have any comorbidities which could impact his contrast sensitivity. You should know what is the pupil size. And of course, you should have gone through very unbiased peer-reviewed literature of different IOLs, and then ensure that you're well educated and experienced. And of course, the patient has to be made to understand that they should have very realistic expectation. Some potential visual side effects are there. We need to explain to the patient that there is this thing called neuroadaptation, that even if they are initially not well adjusted, the brain is so plastic that in 3 months to 1 year, they should be able to adapt well, and the younger patients definitely do even better. So probably the question now is, we need to understand about each of these IOLs and individualize our IOL selection. So this optical principle is based on focality, like it could be refractive, it could be diffractive, or a combination of both. So when we talk of monofocal lenses, we all know that there is single focal point. With a diffractive, there is one far and near focal point, and refractive, there are multiple foci, because of which the visual disturbance is significant. Multifocal IOLs also work on the principle of simultaneous vision, wherein if one image is in focus, the other image is in out of focus image is actually suppressed. And it is this suppressed image which is the cause for halos. So, but then we also need to remember that no visual system in a mammal has multifocality. So our aim is to ensure that you're able to give visual freedom, good quality of vision, and choose an IOL which gives maximum physiological division of light. Trying to understand some very basic optical principles based on which different IOLs, multifocal IOLs have been designed. One, we need to know about the diffraction order, in which if a light comes to hit a barrier, it gets diffracted. So when it gets diffracted, the light which goes to the distance is called the zero order of diffraction. The light which goes to the near is the first order of diffraction. And then the second order is always double that of the first order. So if the distance is, for distance near is 3.5, that is the first order. The second order of diffraction becomes +7. Now this +7 becomes very close to the eye, and this is a light which gets wasted. So in bifocal diffractive lenses, what they said, they have 40% of light, non-deviated light, which goes to distance, 40% of deviated light goes to near, and 20% of the remaining light is actually getting wasted. This is one concept which you need to know. So the concept of the IOL designs have gone and modified so that the wastage of the light is being reduced to get a better quality of vision. The other thing is the energy distribution, which is based on the steps which are there on the multifocal lens. Now, there are steps which are low, there are steps which are high, there are steps which are closer, and there are steps which are wider apart. So the lower the steps, the more the light is transferred to the distance. And as the steps become higher, more the light is transferred to near. So that's one thing. The other thing is, the closer the steps are there in the multifocal IOL, more of the light goes to near, and the wider the steps, there is more light going to distance. So then there is a play of the height of the steps being regulated and the width of the steps being regulated to ensure light goes to distance and near. The other principle in multifocality which was adopted was apodization. In apodization, it is the amount of energy which goes to distance or zero order and which goes to near or first order. Now, it is supposed to be non-apodized if the amount of light which goes to distance is equal to the amount of light which goes to near. It is said to be apodized if there is more light being distributed for distance than for near. Trying to understand how the multifocal IOL graph built up. If you go from 1997 came in the array, people were happy, but there were a set of complaints. Then came the resume in 2005. Then came restore in 2005 itself with a +4 ad. Then it went on to +3. By 2015, we had the active focus restored. By that time, we had even the pan optics. And by 2016 came the Symphony IOL. So in what was a big change with the apodized lenses of Restore when it came in was, it provided a 3.6 diameter of an apodized diffractive region. So the step heights were reduced from 1.3 to 2.2 micron. And as I had said, the higher the steps were, there was more light going for near, and the lower the steps, the more light was going for distance. what they did when they decided that the near vision was not enough with the availability of computers and the need for intermediate vision, they came to Restore 2.5, wherein what they did was a very small central knuckle of 0.94. They made it refractive, that is totally for distance. And on either side was the apodized rings. They also reduced the number of rings so that there would be less amount of light scatter and the dysphotopsia symptoms. And they ensured that the diffractive area was lesser in the 2.5 as compared to the +3. And what they did was, by doing this, there was a greater usage of light energy of 87.4 as against 84.5. Then came the Technis multifocal, wherein again, they had 22 rings with their earlier Technis multifocal of +4 add. Then they learned and reduced the rings to 18 for 3.25 to 15 rings for the 2.75 add. So now, while all this was happening gradually and patients were fairly getting happy and a mix and match was being done, then came the evolution of trifocal lenses. So in this, what happened was, the concept was that we have to give them great distance and near, but we also need to improve the intermediate vision. And by now, our patients were very clear that they did not want this symptom of dysphotopsia. So when we are talking of near intermediate vision, all along the concept was that it would be 80 centimeters, but we realized that 60 centimeters was more comfortable for a computer or taking food for fridge or a car dashboard. So when we talk of trifocals, the three trifocals which reigned the market was the Acrisoft PanOptics, the Fine Vision, and the AT Lisa lens. So when we talk of fine vision, I'm just going to give you a very bird's eye view. This was built on two profiles. Again, two profiles which got together. The first profile, as I said, had 0 order for distance, and the first order of +3.5 for near. And the second order, which is double that of first order, was +7, got lost. So then the second profile which they had a far vision, and the first intermediate was 1.75, and the second order was double that of the first near point, and that became 1.5 into 2, 3.5. So this 3.5 got ordered on to the first profile, and together what they found was they were able to make up for 4% of the 20% loss was brought back in to get a more useful vision. How the AT Lisa trifocal was conceptualized was they had a central trifocal of 4.3 millimeters surrounded by a bifocal up to 6 millimeters. The traditional trifocals, very briefly, had two steps. One was a base curve, which was for distance, and the two steps it was worked out such that the first near was at 40 centimeters, and the first order diffractive would be twice that of 40, 80. So it was distant vision, 40 and 80. So, but then I have been earlier telling that we need 60. So then came the quadrifocal, which had a base curve for distance and 3 step heights. So the 3 step heights were 40, and then came 60, which was 1.5 times of the intermediate point, the first focal point. And the second one was 3 times that of 40. So it was 40, 60, and 120. Now, what the enlightened optical technology of PanOptic did was, it took away that 120, redistributed it for distance so that you had 40, 60, and a more enhanced distant vision. So this was one way of doing it. The other thing which they modified in PanOptics was that they realized that if the optic diffractive zone was less than 4, it is compromising for near and intermediate vision. If it is larger, it was compromising for distant vision in mesopic light. So then they came at a golden number of 4.5, which seemed to be less dependent on the pupil size or the light condition. So essentially the PanOptics had an optic diameter of 6, a diffractive of 4.5, and it had intermediate at 2.17 and a near at 3.25, and it was on an aspheric platform. Then again, if you look at the comparison of the 3 lenses, which were very popular, trifocals, I'm not going to read out the whole table. All that we'll say is the fine vision was based on the concept of apodization, whereas AT Lisa and PanOptics were non-apodized. They had different ranges of near add and intermediate add, which seemed to be suitable to the patient once they got adjusted.
the energy loss incidentally was lesser in PanOptics as compared to AT LISA and fine vision, which was, however, not too dramatic. So then when we're talking of the earlier restored and the techness, and then I go on to trifocal, we also need to have a brief idea about how they all perform. So this was a study by Cohen et al., who said that PanOptics consistently did well in all ranges of distance. And then it seemed to make relevant to compare PanOptics with fine vision, which again in this study, it showed that PanOptics from 0.5 to 2.5 D focus curve did better than fine vision. That means it was a little better than fine vision for intermediate vision. As far as the photoptic symptoms are concerned, PanOptics seemed to do better. Then in this, all this was happening, there was a symphony which was also evolving, which was using the excellent techniques technology with stay, along with its HLA design, which allowed that extended range of focus. And then it had an achromatic technology, which ensured that it did away the chromatic aberration and the visual disturbances, which was because of that. And it had its own central zone and surrounding 9 rings. And it was all planned to optimize the light utilization so that dysphotoptic symptoms were less. So then how was Symphony better? Now they compared, this was a study done by Beatrice et al., wherein they compared a group of eyes wherein it was monovision and the other wherein it was non-monovision. Monovision, what was done was the first eye was operated, and if there was a little disturbance in the near, the other eye was made a little myopic to ensure that the patient had good binocular vision. So then again, there was another study which by Ruiz et al., which compared the PanOptics with Symphony, which again reiterated the PanOptics actually did better than Symphony in spite of the micromonovision for near vision. However, having said that, there were many patients who were equally happy in each of these groups. While all this was happening, essentially it was a play of heights and widths and apodization and utilization of light energy. The Indian multifocals were definitely not way behind in the market, and therein came the different lenses. And of course, it is an individual acceptance and understanding of the optical design and compare and a very excellent surgical performance, having the right kind of a rexus wrap and the positioning or the centering of the IOL, which all made it additive that today multifocal have come to stand. But then before I would conclude, I would like us to know a few more things. Like we need to be cognizant of what the patient wants. The patient may want a low ad. You could look at a plus 2.5, plus 3 lens. He may have reading need for reading more. Then you would think of giving a plus 4. If he is happy with an intermediate vision, you would think of a Symphony. If he wants great vision at all distances, you would look at a trifocal. So now I'm going to show you very rapidly 3 kind of situations. Now this was a patient who had an LRCS with a Symphony multifocal, had great distance and intermediate vision, but was little hampered in the near vision. So this is the time when you could plan a techness plus 4 in the non-dominant eye to give him a great near vision. This is another patient who again had a Symphony, again had a smile a little impacted in his near vision. So what was done in this patient was the second eye was titrated and made 0.75 diopter myopic, which helped him made him very happy for his near vision in that eye. There is a third set of patient who has had Symphony in both eyes. Binocularly, he's a happy patient. Although he has a small myopic and astigmatic error, I would be foolish to interfere with him. I would just leave him alone. Causes of dissatisfaction, how they are going to be handled, would be discussed in great detail by Dr. Ramurthy. But the only message I want to leave is, we need to know that the value of multifocal far exceeds the temporary discomfort and that very short-term dysphotopsia some of these patients complain of. We should make it our objective to understand optics better and the multifocality which it has offered. And I'm telling you, with all the combination of information and good surgical confidence, this new technology would be embraced by most of us at our doorstep. Thank you.
Thank you, Dr. Chitra, for this extensive understanding about multifocal IOS. And I would request Dr. Ramamurthy to continue from where she is left and let us know exactly where to use which one. And then after that, we could probably have a small discussion on this and then take the last one.
Thank you. I'm a bit of a quandary because most of my slides have already been shown. I think that's the problem in both presenting from the same home. But anyway, I'll try to give a different twist and maybe emphasize on points which are important for optimizing multifocals. I think preoperative counseling is extremely important. As we always discuss, we under-promise and over-deliver. It's never a throwaway glasses, complete freedom, etc. What we emphasize is that once you have this technology, your dependence on glasses will go away. We tell the patients that you buy freedom from glasses for all distances, paying the currency of contrast. So some amount of dysphotopsia, irrespective of the kind of lens that you opt for, is likely to be there. Because the brain adapts more easily, both eyes have the similar kind of intraocular lens. You always tell them after the second eye, first eye surgery, you could consider early second eye surgery. But having said that, there are many patients who, subsequent to the first eye surgery, have been extremely happy, and because it's an early cataract in the other eye, even without the need for glasses, they live for a few years without before getting the second eye operated. So don't make it a rule, because sometimes the patients get put off by the kind of expense involved with bilateral surgery, but make them aware that a second eye surgery may be necessary. We always tell them that touch-up procedure may be necessary, which is always done free of cost, where any residual error is taken care of. And neural adaptation, as we'll see, is a big friend that we have. And as was already mentioned, these are the 5 C's, not just preoperatively, but perioperatively, that we concentrate on. Earlier, whenever our optometrists used to say that the patient is reading 6, and 6, and it was a dissatisfied patient, we put them down to be a difficult, crazy patient. But I think it was a limitation of our understanding of the intricacies involved, our ability not to measure some of these aspects, that left us thinking that if the patient is able to read the chart, and the patient must be having good vision, it's just a difficult patient. Obviously, it's not so, and we have to look at all these aspects when we are dealing with multifocal intraocular lenses. As I mentioned, we have always been successful as physicians when we have done things physiological. When there is an opacity which comes in the eye, we remove it and give a clear lens. The patient is happy. If the blood pressure, the intraocular pressure goes up, we bring it down. But then putting in a multifocal intraocular lens, or even a multifocality in the cornea, as in presbyon, is non-physiological. It's never in the scheme of things. And none of the mammals have this. And maybe because we are not mimicking that's physiological, maybe that's the reason we have these problems with dysphotopsia, but that's a price we have to pay. When it comes to the success with multifocals, these are the various aspects that you need to deal with: patient's age, lifestyle requirements that they have, and the psychological profile of the patient. AA plus personality, who talks a lot about the kind of floaters, wants to insist on a drawing and tell you how he perceives it, and tells about the primarily they're coming to you for surgery because the glare problem that they have during night driving. Obviously, these are not the patients who are good candidates for a multifocal intraocular lens. Again, coexistent comorbidities like, say, a dry ARMD, glaucoma, corneal opacity, EBMD, etc., which would itself cause a drop in contrast sensitivity. Again, combining them with a multifocal intraocular lens may not be a good idea. Obviously, if the patients have a large mesopic pupillary size, that would be a relative contraindication, but that's when the problems of glare and dysphotopsia gets magnified. Fortunately, at least in our population, in the older patient, the pupillary size is quite small. It's extremely important that the doctor has to be confident of the technology that he or she is offering. And it's not important that you go through the entire gamut of intraocular lenses that were covered by Chitra. Basically, understand 1 or 2 intraocular lenses and completely offer them quite frequently to your patients, and you would find that you end up with the confidence to counsel your patients and change the patient's attitude towards these intraocular lenses and offer them most frequently. It's a classical case of garbage in, garbage out. Unless your basic biometry is not absolutely accurate and you end up with patients requiring glasses for distance, then obviously the chance of achieving a good results is going to be compromised. So give a contact A scan, immersion A scan in well done manner by experienced hands can often give as good results as laser interference biometry. And it's just that the laser interference biometry is more tolerance towards errors, and it's even in inexperienced hands, you could get good results. But immersion A scan can also match the kind of quality of results, especially in normal eyes. I'm not going to run through the entire gamut of formulae that's available to us, but I think Barrett 2 should be the Barrett 2 universal should be the go-to formula. You also have the Barrett 2 toric calculator, the Barrett 2 K formula. It's incorporated in many of the optical biometers, but just in case you don't have access to it, as we don't have access in some of our peripheral centers, we have made it a rule to access the ASCRS or the APASCRS websites where this is available. And once you employ this, you find that your intraocular lens calculation, even in extremes of eye, is quite good. Another thing is you have to concentrate on the ocular surface, and if not just post-operatively but pre-operatively also, and optimize the ocular surface before taking up these patients for surgery, because that's when you get a good intraocular lens power calculation as well as good post-operative outcome. Yeah, I did mention about AA plus personalities, but don't underestimate this kind of a lady, the kind of damage that you could do to your practice. I often find that busy executives, owners of textile mills, politicians, they may talk to you about the kind of problems they have, but they do not want to talk much about it to others who they meet on a day-to-day basis, because they don't ever want to tell anybody that made a wrong choice in life. But this is a lady who tell each and everybody who comes across that the kind of irritation, discomfort has made her miserable, might drive away quite a few patients from your practice. So be cognizant of the, I don't find that a patient who had a serious problem of a dropped nucleus or an endophthalmitis, I spend a significant amount of time with them. They sometimes come back to me for their second eye surgery, but this is the kind of a person we have to be extremely careful about satisfying them, because this is what can damage our practice quite significantly. And that's the reason that I have this picture over there. And very often these OSD symptoms is responsible for that, and addressing it adequately is extremely important. I'm not going to go into the details of the way you can handle ocular surface. I'm sure both preoperatively and postoperatively, we have to adapt all these measures so as to optimize the ocular surface. The most important factor is postoperative medications. To my mind, less is more. I give steroid drops, pardon me for the names that are mentioned over here. It could be anything else, but this is essentially a printout of the prescription that we give to our patients. Just for a period of 2 weeks, use steroid drops. Subsequently, just non-steroidal anti-inflammatory drops, which do not have any preservatives in them. A lot of lubricant eye drops, usually carboxymethyl cellulose, which is again non-preserved, used for initially for a 6 weeks, maybe even continued for a period of 2 to 3 months. Once I do this, I find not just my multifocal intraocular lens patients, but I ended up with more satisfied monofocal intraocular lens patients also. As far as posterior capsular opacification is concerned, do not wait just for a drop in visual acuity, especially with a multifocal intraocular lens. Even a diaphanous thickening like this, which could be giving a patient with a 6/6 vision or an N6 vision, if the patient has some kind of a visual disability and you have ruled out all other problems, a decentered lens, macular problems, etc., ocular surface problems, going ahead and doing a 3mm YAG capsulotomy would be a good idea, and you would find that often the problems that the patients mentioned does go away. The cataract patients in their 60s and 70s are often the patients who have problems on the retina, which may not be picked up by anterior segment surgeon doing a casual examination. That's the reason that all our cataract patients, not just multifocal intraocular lens patients, undergo a OCT examination of the retina. The incidence of epiretinal membrane is supposed to be 7% above the age of 60 years. So just the existence of epiretinal membrane is not a contraindication for a multifocal intraocular lens, but you'd warn the patient of this, and if it's any crinkling of the macula, then obviously you would stay away from implanting a multifocal intraocular lens in these patients. Diabetes mellitus per se is not a contraindication, but if the macula is affected in any way, even if it's not, the patient does not require any injections in the eye or a laser treatment, still maybe these are patients who are relative contraindications from a premium intraocular lens. Centration of the intraocular lens is not often talked about very much, but in case it's a decentered lens that you have, as you can see, this bilaterally implanted patient just done 1 week apart. This is an extremely well-centered ring, as you can lens, as you can see from the diffractive rings. Here it's decentered. It's not just the multifocal, even a monofocal lens, if it's decentered, would cause a significant amount of coma and trefoil. This is because the good capsular rexis overlap not being there. It has been suggested that you could use a YAG laser so as to pull the iris in this direction so as to center it. I've just done it in 2 cases. Not very comfortable for the patient, inappropriate results. So extremely important that you do not end up with results like this. Having a good look at the topography is also extremely important, especially to make sure it's quite regular. And if you have a significant corneal cylinder, as we will mention later, it's important that you address it with a toric multifocal intraocular lens, because uncorrected astigmatism is left behind, not only requires glasses post-operatively, but also deteriorates the quality of multifocality quite significantly. If you have an access to a machine which is able to give you an idea about the higher order aberrations, it's a great help. This is the internal aberrations. This is from the corneal surface. This is the total corneal aberrations. So obviously, when the lens is removed and all these aberrations is left taken away, the eye is quite pristine. And this is the eye which is going to be doing extremely well with a multifocal intraocular lens. When you have a significant higher order aberrations in the cornea, sometimes they are cancelling each other out, and the patient has to continue to deal with the corneal aberrations. So if it's very high, maybe in the range of a root mean square of 0.5 or more, the corneal aberrations, that would be a relative contraindication as far as higher or doing a multifocal intraocular lens is concerned. Another aspect is the angle alpha. Angle kappa is important when it comes to refractive surgery. Angle alpha is what we look at when it comes to multifocal intraocular lens. The cutoff value is supposed to be 0.5 millimeters, but I have found in my experience that you can be a little more relaxed in that. 0.7 millimeters might be the upper limit. And there has also been a significant study published by Steve Scalon, who retrospectively analyzed patients who underwent removal of multifocal intraocular lenses because of dissatisfaction with the quality of vision. And he found that there was no correlation between the patient satisfaction and the preoperative angle alpha. So this is a measure that I would look into, but do not strictly abide by it. And just in case all other factors are quite fitting in, I would go even up to 0.7 millimeters as far as implanting a multifocal intraocular lens is concerned. And as I already mentioned, if there is significant anterior corneal astigmatism, it's a good idea to go ahead and implant a toric multifocal intraocular lens so as to address the toricity also. So this presentation might give you various other things that you might have heard, might give you an idea that for implanting a multifocal intraocular lens, you need an optical biometer, you need a topographer, you need a abrometer, high-end phoco machines, maybe a laser refractive cataract suit, advanced microscopes, and digital imaging system. Far from it. Obviously, having all those instrumentation is an advantage. And if you're doing a prelex, if you're doing a clear lens extraction where it's essentially a clear lens that you're removing, the patient's expectations are very high. It's a good idea to do all those. But in case it's a cataract surgery that you are doing and you are personally addressing it, standardized immersion age scan, manual and autokeratometry, good formula like the Barrett Universal 2, which is available in websites, good phaco techniques with predictable refractive outcomes, addressing corneal astigmatism, which can be quite adequately measured using a manual keratometer, and complete understanding of the few lenses that you use is obviously a great way to go. And a multifocal intraocular lens can be very much incorporated in your practice. I think when it's a residual error that is left over, prevention is the best way to go about. So spend adequate time to measure the intraocular lens power quite adequately. But then in case there is a residual error that's left over, decide whether treatment is needed. Very often I come across patients who come into the clinic in the post-operative 6 weeks checkup, quite happy with the outcome. But the optometrist makes them sit and makes them realize that they have a residual 0.75 diopters astigmatism, 0.5 diopters a refractive error, and the patient realizes that not the last line is not so clear. So by the time they come to me, there is a certain doubt in their mind. So we have made sure that all of us understand that 20 happy is more important by 2020. In case the objectively we do measure, look for any residual error, but if the patient is not quite happy with the kind of refractive outcome, we do not make sure that they realize that they have a small residual error. But having said that, if the patient comes in with a complaint of not seeing very clearly, we are looking for even that small myopic or a astigmatic error that's left over, because you need to address it either by prescribing glasses by or other measures. Otherwise, the patient is likely to be dissatisfied and may go elsewhere for addressing this. As far as addressing residual error is concerned, various modalities are available. I'm not going to go into all that. As I already mentioned, you can see a PRK procedure being done. It's just about 3 to 4 months subsequent to the surgery. If the significant error is left over, we offer this upgrade free of cost to the patients. And actually, the patients have been forewarned about this. And when we do this, it's not just the requirement for glasses. Many of the dysphotopsia patients, symptoms that these patients have also goes away. Of course, you have to be aware of the fact that the ocular surface can be impacted by this procedure. So you have to optimize the ocular surface before doing this. But I find that when I do this laser touch-up, either by a LASIK procedure or a surface procedure, the patients do extremely well. When there is a significant residual error that's left over, obviously a secondary intraocular lens implantation might be a good idea. This is not a kind of error that you would face with in your routine practice, but this was a patient where we did expect a residual error because of the high amount of today we have a choice in the sense that even our monofocal intraocular lens patients, in case, I'm sorry about that, in case they want a multifocality, there are situations where with a monofocal intraocular lens implant in the first eye, the patient gets a multifocal intraocular lens implanted in the second eye. They're quite happy with the outcome, but occasionally in case they want multifocality be restored in the initial eye, you have choices today. It's available right from Baroda. This is multifocal trifocal sulcus fixation lens that's being implanted. And I believe that this is a kind of lens that restores multifocality even after initial monofocal intraocular lens. This is not something that I encourage, I talk to my patients about, but if there is a demand, you have avenues available to us. This slide was again shown, but please do not underestimate the power of neuroadaptation. I believe the neuroadaptation is both the problem and the solution. And if the patient adequately adapts neurologically, then most of the problems with multifocals does go away. Younger the patient, better is the adaptation. Every time you prescribe a new contact lens, a new glasses, there is a certain amount of neuroadaptation that has to occur. And if you give adequate time, encourage your patients, live with them, then this problem doesn't go away. I'm going to, this is just a point I want to make. Very often the patients complain with some amount of difficulty in night driving, some halos glare. It's more of an observation that they are making. And I have this simple -2 power glasses. This 55-year-old man, when he came with subsequently multifocal intraocular lenses of some amount of dysphotopsia, all I did was to put this -2 diopter lens, asked him to read. He was reading quite comfortably without the need for any glasses. I said, I can do a lens exchange, put in a monofocal intraocular lens, but the multifocal intraocular lens has given you this ability. And yes, the dysphotopsia might be there. It's a small price that you have paid. Do you want me to exchange these lenses? Mind you, I've been doing multifocal intraocular lenses, all different types, for almost 15 years now. But only in 2 of the patients, I have had to exchange, take out the multifocal intraocular lens. It's not that none of them have had dysphotopsia. None of the others have had dysphotopsia. It's just that once they realize what they have gained out of these multifocals and you give adequate time, these patients are willing to adapt. I'm going to skip these slides because Chitra has already talked about them, but I'm just going to go on to my last slide. Mixing and matching these slides, these lenses, whether it be by way of using the same type of intraocular lens, and I think it's getting stuck. So, or by mixing and matching different types of lenses, you find that you are able to optimize your outcomes. This is a case which had a significant astigmatism. I went ahead and implanted a Symphony toric intraocular lens, and this was the outcome that the patient had, where you found that he had a +1 requirement of +1 diopter as far as the hence near vision was concerned. Quite good outcome as far as distant and intermediate vision is concerned. So what I did was to go ahead and implant a Panoptix toric in the second eye, and bilaterally implanted. The patient was quite happy, even though the first eye still required a +1 diopter. I think the second eye surgery is a great help, and that's the reason I always believe in giving at least 2 weeks between the two eye surgery. And depending upon the first eye outcome, I titrate the kind of power, the type of intraocular lens that I'm going to implant in the second eye. Again, this is just to show you the importance of correcting astigmatism quite adequately. This was the time when trifocal intraocular lens has just come in, and there was a significant 0.87 diopters of against the rule astigmatism. Went ahead and ignored this and implanted a trifocal lens without correcting the astigmatism. The patient had 618 vision for distant vision and a significant amount of astigmatism. I did counsel him that we could do a laser vision correction 3 months later, but while waiting, we went ahead and implanted a trifocal toric in the second eye. You can see it's a T3 trifocal toric, and the visual outcome was extremely satisfying the second eye because the astigmatism was quite adequately handled. And 3 months later, we went ahead and addressed this astigmatism on the cornea and bilaterally implanted. The patient did very well. So the final slide, I think whenever the patient comes to you with a complaint, it's more of an observation. You agree with them, tell them that yeah, this is going to go away. You have felt this problem and we have been able to address it. And once you counsel patients and be with them, most often you end up with good results with multifocal intraocular lens, for that matter, with any form of cataract surgery that you do. Thank you so much for your kind attention.
Thank you, Dr. Ramamurthy. You actually gave us so many practical tips to this, and it was really a very enlightening talk. I just wanted to ask two things. What is the role of femtocataract in a premium lens if you are going to put? And secondly, the pupil size, if whether that is also of consideration.
I think the importance of femtocataract is, the ability to do very predictable, repeatable surgery, the kind of a capsular rhexis overlap that you can get, the ease with which you can do nuclear fragmentation, definitely is an advantage. Another very important advantage is the ability to do laser arcuate keratotomies. Especially any astigmatism above 1 diopter, I would definitely go for a toric multifocal. But anything less than that, even if it's against the rule astigmatism, though I do all my incisions temporarily, I go ahead and do a laser arcuate keratotomy. It doesn't completely do away with the astigmatism, but significantly debulks the astigmatism post-operatively. So obviously the marriage of both these technologies does well. But having said that, as I emphasized during my talk, it's not necessary that you need to have a laser machine before adapting multifocal intraocular lenses. I think it's extremely very easy to get good outcomes in multifocal intraocular lenses even without the access to this technology. And as regards the second question regarding the pupillary dilatation, yes, we always measure the mesopic pupil. If it's a very large mesopic pupil of 5-6 millimeters, these are the situations where I will be make the patient aware of it, because that's the situation where the problems of dysphotopsia could get magnified. But most of our patients in 60s, 70s have mesopic pupillary size, ambient pupillary size of about 3.54 millimeters. So at least in the Indian population, is not a major consideration.
A very small pupil would be a contraindication for multifocal dilatation?
In a way, yes, in the sense that, a 1.52 millimeter pupil, because adequate light is not going in, the patient may not have any problems, and the diffraction that occurs at the edge of a very small pupil itself may give them a fair amount of depth of focus. These are patients, you go ahead and implant these lenses, and hope they get a benefit. Nowadays, that central ring itself has been fairly enlarged to about 1.6 millimeters in the modern day trifocals. So I would not go ahead with a multifocal intraocular lens unless mesopic pupillary size is, ambient pupillary size is not at least 2.5 millimeters. Mind you, when you are shining a slit lamp light onto the pupil, is going to shrink. So we are not talking about that, but an ambient pupil which you normally observe, and most often you find that these pupils are about 2.5 millimeters. So very few patients I have refused because the pupil is too small.
Thank you. For want of time, now we'll move on to the next topic, where somebody is at an age where you don't want to do an intraocular procedure of lens exchange, and it is also not suitable for a corneal refractive surgery. And then we do have some solution in the form of ICL or IPCL. And I would request Dr. Partha to please throw some light on that.
Thank you, Dr. Rupal. So thank you very much. And this is something very, very close to my heart and Dr. Ramurthy's heart as well, I'm sure. We learned phakic IOLs together way back in Germany. And it has been a real, very rich journey through the phakic IOLs. And we have some things in phakic IOLs that we are now able to vouch for. And phakic IOLs are there to stay. ICL and toric ICL, these were one of the best lenses and has stood the test of time. Foldable, they are posterior chamber sulcus located and is made up of this collamer, which is collagen and hemicopolymer, and is known for its wonderful biocompatibility and excellent transmittance. And the flexibility of these lenses are phenomenal. And that is how it makes this lens, though expensive, so important for our patients and day-to-day of our practices. So the posterior chamber, the concept it is, and that is how the phakic IOL has shifted from the anterior chamber to the posterior chamber, and that's behind the iris, far from the endothelium. Excellent cosmesis is maintained. It's very close to the nodal point of the eye, and there is a gain in the retinal size of the image, and the optical zone is effective. And it is of a very stable location. Again, if required, it is exchangeable, no fixation to tissues, and therefore does not alter the shape or does not wear off tissues as such. So the features and the availability of these ICLs are large, and they come in different designs. And we have the V4C design now, which are both in the toric ICL as well as in the spherical ICLs. The V4C is again the same design as the V4B, but there is this additional central port, and which was a great landmark in the transition of these ICLs. And this aqua port has been added, and it is 360 microns. And this does not endanger an aberration in the patient's vision, but however, it is an adequate size to ensure a good flow between the posterior part of the ICL to the anterior part beyond the ICL. And it is available for myopic spheric and myopic toric lens versions. So what are the prerequisites? When are we going to say that, yes, you are a person for whom we would require or whom we would advise phakic IOL? So the crystalline lens has to be clear, 18 years of age definitely, and a stable refractive power. And there should be less than a 0.5 diopter of change over 6 months or 1 year. And if it is, and ametropia, and this is not suitable for excimer laser surgery. So it's unsatisfactory vision and intolerance to contact lenses. And of course, the corneal thickness is not adequate when we are not able to do LASIK. However, because of the importance and the improvement of the visual quality of the patients who have undergone ICL, we also offer it to patients who are well read, who are well versed, and who understand the difference between the ICL and LASIK. And believe it or not, there are some patients who want to get a phakic IOL done at this stage because they are so well versed with the advantages of the phakic IOL. So the prerequisites, again, the anterior chamber depth is very important, and it has to be greater than 3 millimeters is what we have now. We used to have it as 3.2 millimeters. That is from the endothelium to the anterior surface of the crystalline lens. And the endothelial cell density has to be adequate. And there should not be an ocular pathology, corneal disorders, glaucoma, uveitis, or maculopathy. So the ocular examination is very, very important, and discontinuation of the contact lens, doing a very good refraction, a stable refraction with binocular assessment is important, anterior segment evaluation, and the measurements. The measurements are extremely important, and we'll just allude to it a little while. Dilated slit lamp examination and fundus examination through the indirect ophthalmoscope, and that is to be taken care of. Then comes the importance of the white-to-white, the caliper measurement. And this is a very important measurement which needs to be taken not by a technician, but by the surgeon himself. And the caliper has to be well calibrated. There has to be anesthetic drops, and it has to be done under the microscope with the patient in the supine position. And once this is done, this is a very good measure of what the sizing of the ICL or the IPCL will be. And this has to corroborate extremely well. And there are methods of doing it. The anterior chamber depth is again important, and the anterior chamber depth needs to be determined between the endothelium and the crystalline lens. The ICL sizing, again, when we do the white-to-white value, the OPSCAN has been the gold standard, but the OPSCAN is not available in many parts of the country as of now, and therefore we resort to the caliper, the digital caliper, which is a very, very good way of determining it. The IOL master shows up two large values, and this might lead to an oversized ICL. But in our practice, we always take the IOL master reading as well, knowing full well that there is an overestimation here, and that overestimation should be the same for both the eyes, and it should be that same difference that we find from the caliper to the IOL master. So it is an indirect method of considering that the caliper reading is accurate and can be taken up. So the sizing is so important because we need that vault and that central distance between the anterior surface of the crystalline lens and the posterior surface of the ICL is important and has to be in the range of 0.25 to 0.75. And this, of course, is measured by the slit lamp. Not measured, it's an eye estimation by the slit lamp. It should be half of the corneal thickness to about 1.5 times the corneal thickness. An undersized lens, and that would be with a vault of less than 0.125 millimeter, may increase the chance of an anterior subcapsular opacification, which we do not want. And if it is an oversized vault, maybe more than 1 millimeter, then it might push up the iris and close the angles, and that could lead to an intraocular pressure rise. So this is the toric calculation sheet, and it is a very accurate method of putting in the ICL. Now the toric ICL has to be marked, and it is marked by the normal methods of marking, whether you use the gas bubble marker or you use it on the slit lamp. And of course, the Varion or the devices that give a proper estimation of the angles are definitely more important. Now, for ICL, it's very, very important that we load the correct way. And this is important, and this is the most important step. And if this is done well, then most of the things are extremely smooth led. So this comes in, and it has to be housed on the cartridge end, and there has to be an equal amount of methyl cellulose and BSS, and it should just vault across the cartridge edge. and then with the front loading forceps, it needs to be pulled into the hub of the needle, hub of the cartridge. And once it is there, it is ready for injection. One needs to see that the central hole is superior most, and that has to be examined under the microscope to ensure that the ICL has folded well and nicely and accurately within the cartridge. Now, if it has not, one understands that this might come in or might enter into the anterior chamber a little lopsided, a little to one side, and thereby the cartridge can be twisted a little so that again it folds out the right side. So these are important aspects that we need to take care of while loading. The insertion of the ICL again is not so difficult, but again a very important step. So viscoelastic has to be there inside the anterior chamber. And when you're putting the viscoelastic in the anterior chamber, it is very important that it is of optimal fill. It is not too overfilled, thereby the movement of the ICL while unfolding will be retarded and it will not fold out well, or it should not be too less, and thereby the ICL might just bounce in and open up haphazardly and might go the wrong side up. So the pupil dilatation is very important, and it's important to place the haptics under the iris once. So it is important that we place the haptic under the iris, and once it is placed, then it needs to go inside, and wherever the iris is getting placed, I'm sorry. The haptics, once they are placed inside, have to go under the iris, and once they go under the iris, it is important that they stay in place, and for the toric ICL, it has to come into an alignment which the marker determines. So once the alignment is there, then things are important, and at this point of time, it is important also to note that for a beginner, it's important so that you can see that I'm rotating the nozzle a little so that it folds out the right way. And once it is the right way up, things are quite easy, and the haptics need to be placed under the iris into the sulcus. And it's important that it is done very, very gently, and you need to go right up to the foot plate to place the haptic in the sulcus. So the post-op results are extremely gratifying, and the patients are extremely happy. Next day itself, there is no significant complaint of glare and halos. Yes, the PIs we had to do when the central port was not available, but now it's not much in use. And a 2-hour post-operative examination is important, and intraocular pressure has to be checked, and an IOP elevation might be because of retained viscoelastic or non-patent iridotomies in those patients in which the central flow was not there. And the ACD definitely should look deep. The ICL vault is very important, and in 24 hours time itself, you should be able to assess the ICL vault, which has to be of adequate size. The ICL complications, I'll just enumerate. There can be a mismatch of power or the size. The intraoperative wound construction is important. The loading and insertion, during loading and insertion, there could be problems. In the early post-operative period, an elevated intraocular pressure can be there. Traumatic cataract, again, these are usually subcapsular cataracts, and they do not usually increase dramatically, and they can be more or less stationary and might not require a removal of the cataract. Late post-op glare and halo, usually in early post-op, it is a possibility, but in late post-op, patients usually get used to it. The iris transillumination, again, is not a very common phenomena, and cataract and glaucoma, these are also quite uncommon. And atypical long-term finding, of course, if you see a pupil ovalization is there, or transillumination is there, or pigment on the lens is there, then this means that there has been a problem in the insertion or in the technique of the ICL. Oversized ICL is, of course, something that has to be taken into consideration. Let us look at the IPCLs, and the IPCLs have come in and are again here to stay. They have added a great deal of importance in our practices, especially because the finances are much less in the IPCL, whereas in the ICL. And it's a hydrophilic hybrid acrylic implant with 6 haptic pads and better stability for the ciliary sulcus. The customization of the implant is a very, very important phenomena and allows the treatment range of emmetropia right from +15 to -30 in 0.5 diameter increments, and in astigmatism up to -10 can also be taken care of. The lens design includes 8 holes, 2 in the haptics, 4 along the optic haptic transitions, and 2 along the optic periphery to determine correct orientation. And the economic advantage is huge. 2.5 times is what the ICL costs of the IPCL, and the placement of the ICL entails a rotation of the horizontal axis. Here with the IPCL, the placement is just 180 degrees in all cases. And of course, the disadvantages for the need of the PI and the KS Aquaport technology in the ICL is obviated. Dr. Ramurthy sir's group had a comparative analysis of the clinical outcomes between the 2 posterior chamber phakic IOLs, and they did find that in both groups demonstrated efficacy, safety, and predictability and stability, and IPCL is an effective and economically viable option for the correction of myopia. Thank you very much, and for the miles and miles of smiles that our patients have at the end of the day.
Thank you, Dr. Partha. Trust you to make a very complex subject into such a simple terms. Thank you so much. For the want of time, we will have the discussion not happening now, but I will post you the questions once they've come to me. I would now request Dr. Aditi to please give a vote of thanks. Dr. Aditi.
A very good afternoon. On behalf of Baroda Ophthalmic Society and entire fraternity, we extend a very hearty vote of thanks to all our speakers today, Dr. Chitra ma'am, Dr. Partho sir, Dr. Ramamurthy sir, and Dr. Sri Ganesh sir, for gracing our refractive meet and sharing your valuable knowledge and insights. We also express our gratitude to Dr. Rupal ma'am for organizing and anchoring the event so well. A big shout to the executive committee members of Baroda Ophthalmic Society to make this event a grand success. A very big thank you to our patient audience for their participation. See you next time. Thank you. Over to Rupal ma'am.
Thank you, Dr. Aditi. That concludes our today's session, and thank you very much for everybody to attend, and for all the panelists to be present at the end. Thank you so much.
Thank you.
So, till then,
Thank you very much. Thank you. Thank you.
Till the next time.